Hello everyone. Very good evening to all of you. Am I clearly visible, audible? Can someone who is live can write down in the chat box if I'm clearly visible, audible, everything is good to go. I will start with the topic. Kindly give confirmation. Hello, am I live? I'm waiting for your response. Kindly write down in the chat box if I'm clearly visible, audible, everything is good to go. I guess yes, it is. So I welcome you all for today's session. Very, very good evening to all of you. So as you all know, today also we are having demo class of ENT. We were supposed to have two demo class of ENT, and this topic we have started yesterday, assessment of hearing, but we couldn't finish it yesterday. So today, mainly, we will see all the tests which are required for assessment of hearing. Whatever needs to understand this topic, that is the anatomy of ear and the physiology of hearing. We have already completed that portion yesterday. So if you all have attended my session yesterday, so today you will have a better understanding of this topic. And I can see many students are new today. So maybe if you are attending the session for the first time, no worries, you can attend it. Okay, whatever you are gaining, it's good. But after attending the session, go on the YouTube and watch episode 1. You must watch episode 1. After that, this topic will be cakewalk for you. So without wasting any further time, I must proceed and continue with the topic. But as many students are new, so I have to give a brief orientation about the batch. Okay, the third Prof Buster groundbreaking course, third Prof Buster 1.0 batch. Right, in this batch, the main highlight is that all these 4 subjects I am going to teach in just 4 months. Okay, many students have these 2 subjects in the third prof and ENT opthal in the final prof. But in this batch, we are going to cover all these 4. So it's better to cover these 2 also. Although if you are having these 2 subjects in your final prof, but better to cover it here only. Okay, in this batch, we are going to cover all these in just 4 months. So 4 months will be the live session, but recordings of all these will be available for 1 year, right? So most of you may be having the university exam of the third prof in the month of September, August or September, not before that, I guess. Final university exam, third prof. Many students are prof students now who are preparing for the third prof university exam. You are going to have your university exam in August or September, I guess. I am going to finish this batch, the 4 subjects, this batch, complete batch with the 4 subjects on 22 February. With 22 February, if you are attending my live session daily with me only in the evening, you don't have to even revise. After 22 February, you are free till August for these subjects. You can start your final year subjects. So I'm providing you a span of 4 to 5 months to read these subjects. It's a big gain. And your third prof subjects will be prepared for your university exam. Definitely you are going to get distinction if you are going to attend my session, and if you're lucky you can get gold also, right? And not only for university exam, these 4 subjects will be prepared for your competitive exam, that is NEET PG or INSCT. You can try all MCQs from any platform, okay, and it will be a hit after attending, depending only on these sessions, my sessions. So it is a double-edged sword, yes or no? And as I told you, daily live sessions will be there. In the evening only, they will be there. The batch has already started and the batch will end on 22 February. 4 months, 10 days to be precise. This is the duration of the batch. The exact schedule is in front of you. Okay. And along with the daily live sessions recordings, I'm providing you printable notes this time. You can take the printout, whatever I'm teaching you in the class, word to word. You will get the PDF, a beautiful PDF, okay, with images. You should take colored printout. You have to take printout of your own. Okay, the 3 type of question bank I'm providing, and the most important thing, I'm going to teach you with 3D models. Yesterday, I told you what is 3D model. Today, you will have a better understanding. I'm going to introduce many 3D models for better understanding, for clinical understanding, especially in the clinical subjects, ENT and opthal. There will be total 87 live session. This is the 6th session today out of 87, 81 more to go, right, for the completion of this batch. So today we are having the 6th session over here. These are the demo session. There is little bit small announcement. We were having the ophthalm, we have already done PSM demo, the 2 days. We have already done forensic medicine demo, and we have already done ENT. ENT day 2 is today. Day 1 is done yesterday, day 2 demo is today. Now, after that, we were supposed to have ophthalmology demo tomorrow and the day after tomorrow. But due to Diwali vacation, many students requested that this demo can be shifted after Diwali. Okay, because many students are going to their hometown and couldn't attend the session because of traveling and all. So we have shifted the ophthalmology demo from 18th and 19th October to 23 October. So there is a 5-day Diwali vacation, And on 23rd of October, we are having single day YouTube ophthalmology demo. It will be a long class in which I'm going to cover this important topic completely. So after today's class, we don't have any class for the next 5 days. And after that, we are having on Thursday, 23rd October, ophthalmology demo, in which I will introduce how I'm going to teach you ophthalmology with the 3D models. Okay, so do attend that. Now, if you have any other query, you can WhatsApp on this number. So let's start the topic. Can I start? Everyone give me a thumbs up. Are you people ready? I'm not audible. Am I audible? Someone is saying I'm not audible. If you have some problem in audio, please use the earphones. You will have a better experience. Am I audible? Kindly reply. Audio is good or not? Audio is good or not? People say. Audio is good or not? Can you say it? Everyone, please, I'm asking. If audio is good, I can continue. Kindly say. Can we continue? Okay. Thank you so much. Thank you for confirming. So let's continue the topic assessment of hearing. We have already started yesterday. How many of you were present yesterday? How many of you were present yesterday? You were present yesterday? We have started this topic on the YouTube. I guess episode 1 is available on the YouTube. So in the first 2-3 minutes, we will revise whatever we have read yesterday, and I will directly jump on the test. The various tests which are required for assessment of hearing. So yesterday we have seen the anatomy of ear. We have already seen the ear is divided into 3 parts: external ear, middle ear, inner ear. Okay, you can see the complete diagram. I have already explained yesterday. So external ear is having 3 parts: pinna, external auditory canal, and tympanic membrane. The pinna which collects the sound. This is my pinna. After that, pinna connects with the external auditory canal, 24 millimeter long. It connects the pinna with the middle ear. So it's a tube, external auditory canal. And the third is the tympanic membrane. You can appreciate tympanic membrane over here. It is having 2 portions, pars flaccida and pars tensa. So this was the external ear. We have seen the details yesterday. Middle ear have only 2 parts. Ossicles, the 3 ossicles, malleus, incus, and stapes. The mnemonic is myth. From lateral to medial, okay, and eustachian tube. So you can see the 3 ossicles. I have told you the structure in detail yesterday. Yes or not? You can see the 3 ossicles. You can see this is malleus, this is incus. You all can identify this is stapes. This is the foot process of stapes. Okay. I told you the joints between the ossicles. I told you the name of this joint. I told you the name of this joint. This joint and this joint, both of them are synovial joint. But this one is the ball, and this one is saddle joint, saddle type of synovial joint, and this one is ball and socket type of synovial joint, if I'm not wrong. So please learn these joints. So you can see the joints, you can see the 3 ossicles. Appreciate malleus, incus, and stapes. We've already seen it. And this is eustachian tube, which is the connection between the middle ear and the nasopharynx. You can see this tube to equalize the pressure on both sides of the tympanic membrane. So we have seen external ear yesterday. We have seen middle ear yesterday. Internal ear. Internal ear have 2 portions: libranth, bony libranth, membranous libranth. So what is bony libranth and membranous libranth? This is bony libranth. This is membranous libranth. You will say, ma'am, they look alike. They are same. Of course, everything is same in them. They are like tube inside a tire. Have you seen tube inside a tire? The shape is same. Only thing, this is hard, this is soft, this is bony, this is membranous. So the membranous libranth is fitted inside the bony libranth like the tube fit inside a tire. So you can appreciate this membranous libranth will fit inside the bony libranth. Okay. Currently, I am interested only in cochlear portion of this. Only in cochlear. The remaining one I will teach you when I will teach you the balancing, the vestibular function, the semicircular canals and the vestibule. So this is the cochlea. So cochlea also having the bony cochlea and the membranous cochlea. I told you this yesterday. Yes. So this is bony cochlea, membranous cochlea, like that. It is 2.5 tons. The bony is filled with the perilymph and the membranous is filled with endolymph. So you can see this is endolymph in the membranous cochlea, and outside it is perilymph. And I told you the name of the membranes. I told you organ of Corti. I told you all this yesterday. I'm not going in the detail. Then I told you the physiology of the ear yesterday. What was the physiology? We start with pinna. Okay, this is my pinna. This is my pinna. Sound is going in my pinna. And ultimately it is going in my brain. Okay, Brodmann's area of 41, the auditory cortex. So from my pinna till my brain, area 41, what is the root? What is the root inside? From my pinna, starting point is pinna, and the end point is auditory cortex. So see the complete route starting from pinna till auditory cortex. We have seen that yesterday. I'm not teaching you, I'm just telling you so that we can continue with the test. Okay, I will start with the test now. So you can see this is the complete route. So first sound goes in the pinna, then it goes in EAC, then going in tympanic membrane, then it goes in the ossicles, MIS. From the stapes it goes to cochlea. From the cochlea it goes to 8th nerve. It goes to 8th nerve. After 8th nerve, it goes to the brain. In the brain, the mnemonic is E. colima. You know 8th nerve. I told you this mnemonic. E. colima, A is auditory complex. It is 8th nerve, and I told you it is cochlear nucleus, superior olivary nucleus, lateral lemniscus, inferior medial geniculate body, and auditory cortex. So this is E. colima. This is inferior colliculus. So this is complete E. colima. And finally, it is reaching to 8. Now, people, today I will teach you all the tests in this diagram. Please revise it well. If you have, yesterday you have missed somewhere, please, this is our pacer diagram. If you want to understand all the tests in detail, this diagram I'm going to show you nearly 100 times today. In every test, I will show you this diagram. I will show you all the tests in this diagram, and I'm having my patient clinical model with me. I mean, not real patient. In that, I will show you the test. Got it? Say yes. Okay, so this is the diagram. Again, I'm saying, please revise it. Sound goes to pinna. From the pinna, it is going to external auditory canal. From external auditory canal to tympanic membrane. From tympanic membrane to ossicles, MIS. From ossicles, it's going to stapes. Stapes say cochlea. From cochlea to 8th nerve. And from 8th nerve, it's going to the brain. This is 8th nerve. And this is complete brain. Colima. This is the full form of colima. This is brain. The various nucleus in the brain. And finally, it is reaching to the auditory complex. Area 41. This is how we can hear. Everyone give me a thumbs up if you have understood. So this is the complete route starting from pinna ending on auditory cortex. Appreciate the auditory cortex over here. So pinna to auditory cortex. You know the complete route because I will do the various tests that will test the various functionality of the complete pathway. You should understand this pathway. People say, please be fast and sane. Are you there? Are you understanding it? Just a second. I guess you are. Okay? Yes. So this video I have shown you yesterday. Starting with pinna. Start with pinna. And with E. colima. E. colima ka A. So we have done that yesterday. Now I have started hearing loss. This little bit modification on the slide I have done. What are the types of hearing loss? There are 3 types of hearing loss. Conductive, sensorineural, and mixed. Mixed is both. So basically 2 types of hearing loss, conductive and sensorineural. Okay. So if there is any obstruction in the external ear, from where to where we have external ear, we have revised it now. From where to where we have external ear? From pinna till tympanic membrane. If there is obstruction anywhere, it is and in the middle ear. Okay, this is external ear. This one is external ear. Okay, middle ear is ossicles and eustachian tube. This is middle ear. The 3 ossicles and the eustachian tube. This is middle ear. This is conductive hearing loss. So where is conductive? Conductive ka matlab there is obstruction in external plus middle ear. There is obstruction in external and middle. So external and middle ear obstruction is known as conductive hearing loss. Please mark it. Conductive hearing loss means obstruction in external and middle ear. Say yes. So any obstruction in pinna, EAC, tympanic membrane, ossicles, or eustachian tube, it leads to conductive hearing deafness. Conductive. Before starting the test, you must understand what is conductive hearing deafness. Tests are very difficult. I'm warning you. I'm not scaring you. But that's the fact. You are getting it? Say yes. Got it? Okay. Just a second. So that is conductive hearing deafness. What is sensorineural? Sensorineural is inner ear and the brain. Any dysfunctionality in the inner ear and the brain, inner ear and the brain is sensorineural. First you learn the basic. Conductive hearing loss, problem in external and middle ear. You know the parts. And sensorineural hearing loss, problem in the inner ear or in the brain. Now sensorineural is of 3 types. Sensorineural is of 3 types. Cochlear, retrocochlear, and central. So you see, if there is problem only in inner ear, if there is problem in inner ear, If there is problem in the inner ear, this is known as cochlear deafness. If there is problem in the eighth nerve, E. colima ka E, this is known as retrocochlear. And if there is problem in the colima, this is known as central hearing loss. So these three are the types of sensorineural. This I didn't told you yesterday. So what is conductive? What is sensorineural? Conductive is there is some disorder in external and middle ear. That is conductive deafness. External and middle is conductive. What is sensorineural? Sensorineural is inner ear and brain. There is some dysfunctionality in the inner ear or in the brain. Now it is of three types. What are the three types? Cochlear, retrocochlear and central. Cochlear means problem in the cochlea. नाम में ही है. Cochlear माने cochlear. Cochlear माने cochlear. That is inner ear. Retrocochlear यानी eighth nerve. Can you see? This is eighth nerve, which is connecting the ear with the brain. This is the eighth nerve, the blue color structure. Can you see? So this is the eighth nerve, which is arising from the hair cells of the cochlea. Yesterday I taught you. Outer hair cell, inner hair cell. The dendrites of these cells constitute the eighth nerve. So eighth nerve connecting the inner ear with the brain, and then E. colima. So if there is some problem in the eighth nerve, it's retrocochlear. And if there is some problem in the brain, anywhere, colima, either problem is colima, anywhere, it is known as central deafness. So these are the three types of sensorineural. Everyone give me a thumbs up. You got it better today, the types of the deafness. So the summary, any problem in external and middle ear, it's conductive deafness, and any problem in inner ear and brain, it's sensorineural. The sensorineural is of three types. The sensorineural is of three types. If there is some problem in the cochlea, it's cochlear. If there is a problem in the eighth nerve, which is connecting the inner ear with the brain, it is retrocochlear. And if there is problem in the brain, it's central. So cochlear, retrocochlear, central. This is what I told you till now. Okay, so we have understood. Let's start the test. Yesterday I taught you these three tests. They're very easy. Okay, we will revise it. Rinne test I didn't taught you completely. So today we will start with all these tests. I will start with this one. I will complete all this. And from special test, we have to take only important one, not all. Okay, so I will complete these also, the important one. So the complete chapter we are going to cover today. So can I start? So let's start with the clinical test. Can I start with clinical test? In the clinical test, these three were done yesterday. Quickly in one slide, we will revise it. What are the three tests? Say the names. What are the three tests? The three tests are, you can see, the finger friction test, watch test, and speech test. Finger friction test. I told you. So this is my patient and this is my finger and the thumb. So what I am doing? I am just rubbing the finger and the thumb in front of patient's ear, which I want to test. Okay, do it in your own ear. You can hear the sound. And I will ask the patient whether you can hear the sound of the rubbing, yes or no. It's a very rough test. Okay, no standardization. And we don't usually perform it. It's a quick rough screening test, not a definitive test. So finger friction test. We have done that yesterday. Second test is watch test. So we will take a watch, clicking watch, and put it in front of EAC. Okay, 2 centimeter away from the EAC. Okay, and ask the patient whether you can hear the clicking sound, yes or no. So again, it's a rough screening test, obsolete nowadays, and we don't use it. The third test yesterday I taught you is speech test. Again, it's a rough screening test, speech test. So this is my patient. Okay, the examiner stand 6 meter away from the patient, 6 meter away. Okay, the eyes of the patient is blinded to prevent the lip reading. Okay, examiner is at 6 meter. Now examiner start talking. Ask the patient at normal sound. Normally we talk with each other at conversational intensity. So ask the patient whether you can hear or not. If the patient say yes, I can hear, patient is normal. But if the patient is say no, I can't hear, so distance is reduced, and we notice the minimum distance at which the patient can hear the sound. So here the normal sound, conversational sound, as well as whisper sound, we notice these two distance, based on which we judge whether the person is having mild, moderate, or severe or profound hearing loss. So that is the speech test. How many of you got it? So this is the speech test. So we have done these three tests. We have revised these three tests. Okay. So these are the three tests we have done. And now, till now it was a revision, people. And now I am starting the tuning fork test. Okay, which will be a new topic for you. So let's start tuning fork test. Can we start? Chalo, everyone is ready? Give me a thumbs up, everyone. Can we start? So we have revised the anatomy very quickly. We have revised the physiology, which is very important for today, very quickly. And we have started the test. In the test, these 3 tests we have just seen yesterday, we have revised them. And now we are starting the 4th test, clinical test, the 4th clinical test, that is tuning fork test, which is of 6 type. I will teach you all 6 type. And let me warn you, they are difficult. Okay, they are conceptual. I mean, you have to understand, you have to be attentive to understand all these 6 tests. There are 6 type of tuning fork test. I will teach you all 6 one by one very quickly. First is Rinne test, second is Weber test, third is ABC. What is the full form of ABC? Absolute bone conduction. ABC, absolute bone conduction. The fourth is Schwabach test, then Binge test, then Gelle's test. We will see all 6 one by one. Let's start with the first one. Okay, before I start all these 6 tests, let me give you the principle of the tuning fork, the basic knowledge regarding the tuning fork. So this is the tuning fork. Okay, how to activate the tuning fork? Yesterday I told you. So I told you how many type of tuning forks available yesterday. Okay, various frequency. So you can see this is the tuning fork. These are the prongs of the tuning fork. This is the stem of the tuning fork. Okay, you can see this is the head. Okay, you can see, and this is like how we activate it on the hard surface, on the palm. We just strike against it. I can feel the vibrations. This is how we activate it. Now with all tuning fork, we have to test these 2 things based on which our 6 tests are there. In some of them we test AC, in some of them we test BC, in some of them we test both AC and BC. So what is AC, what is BC? I will use this terminology in these 6 tests. So before I start these 6 tests, you should understand what do you mean by air conduction and bone conduction. That is AC and BC. What is air conduction? What is bone conduction? What is AC and BC? Okay, so one by one we will take it. First, let's take AC. AC, air conduction. How to test air conduction with a tuning fork? So we will take a tuning fork, we will strike it, activate it, and keep 2 centimeter away. 2 centimeter away from external auditory canal. 2 centimeter away. And ask the patient whether you can hear the vibrations, yes or no. So it is known as air conduction because here the sound is going via air inside the ear. Yes or no? Let me perform in front of you. So this is my tuning fork, you can see. I'm activating it and keeping it 2 centimeter away from my ear. I can hear the vibrations, yes. So my air conduction is okay in this ear. Let's test another ear. Again, I can hear the vibrations well. So my air conduction is well in both the ears. You are getting it? So this is how we perform it. Say yes. So what we are doing? Vibrating the fork, placing it 2 centimeter from EAC like this. So sound waves are going. Why I can hear? Listen, listen, listen. Listen at me. So this is how I am vibrating it. Listen. Listen. Now this is my tuning fork. Please understand. Okay, I am vibrating it and keeping it 2 centimeter away from my ear. Yes or no? This is approx 2 centimeter from my ear. Okay, now the sound waves are going and I can interpret it. So starting from my pinna till ecolema, I am perfect. My pinna is good, my EAC is good, my tympanic membrane is good, my middle ear, my inner ear, my brain, the complete auditory pathway is good. And from pinna till A, auditory complex, okay, area 41, everything is good in this ear also and in this ear also. That's why I'm hearing, yes or no. So this is what we are checking here. You are getting my point? This is what we are checking here. Let me show you. So that's what is shown to you. So what we are testing in AC basically. In AC, how the sound travel from pinna, you can see, and reaching in the A, auditory complex. How? This is the complete pathway. So it is going to pinna, EAC, tympanic membrane, ossicles, cochlea, 8th nerve, and ecolema. And finally, it is reaching ma, ecolema ka ma, from pinna to ma. That's why the person can appreciate. So basically, AC tests 2 things. AC tests the conductive pathway. This is known as conductive pathway. This pathway till here, it's known as conductive pathway. Okay, external and middle ear. And it is testing the cochlear pathway. So it is testing both. AC is testing both. If sound is going from pinna and reaching till auditory cortex and everything is good, so both the things are tested. Okay, so conductive pathway is also tested and cochlear pathway is also tested. I'm having both well. That's why I can hear the sound via AC. People say yes if you're getting it. So here you see only this one. Don't see this one. You see this one. So I'm keeping the tuning fork 2 centimeter away from the pinna. Okay. You can see the sound is traveling from pinna till the complete A. Okay, so I'm testing the conductive pathway as well as cochlear pathway. It is testing both conductive and cochlear, the same thing. Now let's come on BC. Can we come on BC? Let's come on BC. In BC, what we are doing? See, we are activating the tuning fork. I will show you. And we are keeping the foot plate of the tuning fork directly on the mastoid. This is my mastoid. Behind the pinna, the bone behind the pinna is mastoid. You can see this is mastoid. This is mastoid. So just below the mastoid, we are having cochlea. So we are directly activating cochlea. You are getting my point? So vibrations directly activate the cochlea. So we are bypassing the conductive pathway. So what we are doing, see the red line over here. I am giving stimulus over here. This is my mastoid. Here, this is my mastoid. I am giving stimulus directly over here. You can see this is the mastoid. I am not giving stimulus here. It is not going via air. No, it is going via bone. So this is the mastoid. I am stimulating directly mastoid. It is going here. And from cochlea, it is going to ecolema. From cochlea, it is going to ecolema. So I'm not testing this. I'm not testing this. I'm testing this and testing this. So BC test. BC don't test conductive pathway. No, it don't test external and middle ear. BC test cochlear pathway. It tests inner ear. How many of you got it? So this is BC. You can see this one. So here the foot plate of the tuning fork, I am directly keeping on the mastoid. The vibrations. So it is vibrating the bone. The vibrations are going via bone, not via air. That's why it is known as BC. Here the vibrations are going via air. And here the vibrations will go via bone. That's why it's BC. It directly stimulates cochlea. So it is bypassing the conductive pathway. I hope you got it. So this is the summary I want to tell you. Okay. So AC test, conductive and cochlear, both pathway, and BC test, only cochlear pathway, not the conductive pathway. You are getting it? You can see AC and BC. People, this is our, you can say, the base diagram in which I am going to teach you all the tests. If you understood AC and BC, you are allowed to attend the further lecture. If you don't understand AC, BC, there is no use of attending it. Okay, my conversation ahead for the next 2 hours will be in terms of AC, BC. So what is AC? What is BC? Air conduction, bone conduction. See the 2 red lines. What we are doing in AC? We are putting the vibrations over here. Tuning fork vibration 2 centimeter away from the pinna. They go via air. Okay, so they go with this route. Appreciate the route. And ultimately they reach the auditory cortex. Okay, so we are testing the conductive pathway. This is conductive pathway and cochlear pathway. We are testing both. But in BC, we are activating the tuning fork and keeping it directly on the mastoid. So it is activating directly the cochlea. Okay, we are bypassing the conductive pathway. And it is via cochlea. It is going to ecolema. So here we are testing only cochlear pathway, not the conductive pathway. That's what it is written here. This is AC, this is BC. Everyone got it? You want me to do it? Huh? Now you tell me. Use your common sense. I guess everyone have that common sense. Okay, I'm not asking about the ENT knowledge. I'm asking the common sense. Everyone have it. You tell me which one is longer. See it now. See on the board. Which one is longer? So AC include, again and again I'm saying, conductive and cochlear both. BC include only cochlear. So obviously the length of AC is longer than the length of BC. Yes or no? Common sense, no? Common sense. No knowledge, only common sense. You can see it here. If you understood what is AC, what is BC, you can comment. Ki ma'am, AC, for AC, the sound wave have to travel from this to this. It is longer. But for BC, it is traveling only this. It is bypassing the conductive pathway. So AC is longer than BC. Okay. So length-wise, this one is longer. Intensity-wise, this one only is louder. So this is longer and louder. Longer and louder. Length-wise also, this is longer. Intensity-wise also, this is louder. This is louder. Because sound waves are perceived better in air as compared to perception in the bone. So this is louder also. And this one is longer also. So you can see normally I don't have any deafness. Okay. So my AC is better than BC. Length-wise also, intensity-wise also. So it's longer as well as louder. Longer and louder. AC is longer and louder than BC. AC is longer and louder than BC. Yes or no? You got it or you didn't got it? That's what I want to tell you. So you can see here, this is AC and you can see this is BC. So this is AC. AC is longer and louder than BC. Okay, everyone got it? Whatever diagram you want to understand, yes or no? So now I will start the test. If you understood this concept, AC and BC. AC is longer and louder. Okay, so we will perform both the tests in front of you. And We will move further on the test. So I'm performing AC and BC on me. Let's take my right ear as a testing ear. Okay, on the right ear, I will test my AC and my BC. Okay, so I'm testing AC first. Okay, so I am activating the tuning fork and keeping it 2 centimeter away from my EAC. I can hear the vibration. Till now I can hear, yes. Now they are dampened, they are very subtle. Now almost they are absent. Okay, so this was the length of my AC. If I have a stopwatch, I must see the time duration for what I have noticed it. Now I will again activate it. I'm doing BC. I will again activate it. Just a second. I'm activating it and keeping it on mastoid. This is my mastoid. I can hear it, but I can feel the intensity was much better in AC. Here intensity is less and it lasts. So it was definitely for shorter duration. So we must measure the number of seconds here and the number of seconds here, okay, on a stopwatch, and then it will be objective criteria. So AC is longer and louder than BC. This is how we can do. If you have tuning fork, kindly perform it. If you don't have, purchase it. If you're a third prof student, you will need a tuning fork in your clinical postings also. You should purchase a tuning fork of 512 Hertz. That is most commonly clinically used. It's an MCQ also. Okay, so you can purchase it and you can perform on your own ear. Okay, in your friend's ear, in any your relative, patients. Yes or no? So you will have a better understanding. Chalo, we will come back and we will start the test. Everyone give me a thumbs up, people. I'm teaching you with such engaging techniques, but you people are such quiet audience. I don't know why. So keep interacting. I can see the comment box. Chalo. So can we start the test? Yes or no? I will show you the test on my patient. I'm having a clinical model of a patient. I will introduce it. Okay. With these tests. I will perform these tests on the clinical model. Patient model. So let's start it. Can we start? Chalo. So these 6 tests I will teach you one by one. If you got the basic principle. What basic principle I have learned till now? I have learned in tuning fork, normally AC is greater than BC. Okay, intensity wise also, length wise also. So AC is louder and longer than BC. This is what I have learned till now. Okay, G, got it. Let's start the first test now. One by one, we will do all tests. Now, I request all the audience, everyone who is watching me live right now, and the one who will watch the recordings later on, thousands of students. Okay, now, please take out your notebooks. Make this table with me. Okay, the 6 tests you can see. Okay, now what is the result of these all tests? Normally, in conductive deafness, in sensorineural deafness. Please make it. If you're not making it, you are doing a big mistake. Again, I call them master charts. Okay, so make these master charts with me so that you can revise the summary of the chapter in just 1 minute after ending the topic. It will take me 40 minutes to teach you the 6 tests. Each test will take 5 to 7 minutes. It will take nearly 40-50 minutes to take all these 6 tests. Okay, but you can revise them in 1 minute if you are making this table with me. So take out your notebooks, pen, and start making this table with me. Yes or no? So we will fill this table. I will fill with you one by one row I will fill, and the table will be like this. The final table will be like this. I will give you the ready-made version also if you wish, if you are a lazy one, but you should fill it. If you are writing it, it is imbibing in your mind. Okay, let's start with the first one. Are you ready? Let's start with the first one, Rinne test. Okay, for all these 6 tests, my headings are fixed. I will teach you all these 6 tests in 4 fixed headings: principle, procedure, interpretation, and diagram. Okay, you also have to write your answer in these 4 headings for not only for these tests, for all these tests. You have to write down in these 4 headings. My complete test, all these tests you will get in these 4 headings. Okay, so principle, procedure, okay, interpretation, and diagram. Let's start with the first one, Rinne test. Okay, let's start. Let's start with the principle. Principle of Rinne test. Okay, learn these 4 headings if you're preparing for prof. So let's start with the principle. Always write the principle of the test. What we are doing, we are comparing AC and BC of the same year. Highlight the word same year. Same year. The same year. Take my right ear, suppose. Okay, I'm testing my AC, I'm testing my BC and comparing both. Comparing my own AC with my own BC of the same year, not of 2 year. In Weber, we will take 2 different year. Okay, right and left. No, currently I'm taking any one of them. Either take right or take left, but take one of them. Do AC, do BC, compare it. Do AC, do BC, compare it. So compare the AC and BC of the same year. So we perform BC first and then we perform AC and then we compare which one is longer. You know normally what happens? Normally AC is longer than BC. Okay, this is normal. But what happens in conductive deafness? We don't learn. We will use our common sense. What happens in sensorineural deafness? Again, we don't learn. We will use our common sense if we have. Okay, see, it's very easy. Now, if you understood the basic, if you have attended my yesterday's session and today's session till now with attentivity, these tests are fun for you. Take my words. So this is the principle. Learn the principle. We compare AC and BC in the same year. Either this year or one by one. Compare AC-BC first of this year, then compare AC-BC of this year. Like that. Okay. So whatever is your test year. So this was the principle. After principle, what is the next heading? Procedure. So how to perform it? How to perform it? We take the tuning fork. First, we keep it on the mastoid. Okay. Wait for the, activate it, I mean. Activate, keep it on the mastoid. Wait for the vibration to dampen, to slow down, to stop. Once the vibration are stop over here, immediately, then very same second, you shift it on the 2 centimeter away from the AC and see whether you can still hear it. Normally, AC is longer than BC, na? Normally, I told you AC is longer than BC. Normally. So, if you are a normal person, if the vibration ended over here and immediately you are shifting the fork over here, you should still hear it. Let's perform it. Okay, so this is normal. You are getting it? So let's perform it. Let me perform in front of you. So what basically we are doing is Rinne test. This is my test here. You all can see my test here. You all can see I'm having a tuning fork. So what I'm doing, I'm performing Rinne test. So my test here is right here. I will compare BC and AC of my right ear with each other. Normally AC is greater than BC. Okay, so first I will do BC, then I will do AC. If AC is greater than BC normally, and if I'm normal, okay, so after completing BC, AC should continue. Let me tell you. So first of all, activate the tuning fork like this. Activate it. After activating, keep it on mastoid. I can hear. Now it stopped. Immediately after it stopped, I'm shifting it here, but still I can hear. So here when it stopped, I'm shifting it here, but here it's continued. So it indicates my AC is greater than BC and I'm normal. Thankfully, I don't have deafness in this ear. Okay, let's check over here. So here also what I'm doing the same procedure. I'm activating the fork, keeping on the mastoid. I can hear the vibration. I can feel. Now it stopped. I'm immediately shifting it. But again, I can hear. So when it stopped here, you shift here and again you start hearing. It indicates your AC greater than BC. But suppose I'm having some sort of deafness over here. Okay, I'm activating the tuning fork. I'm keeping it here. I can feel. Now it stopped. And if I'm putting it here, I can't feel. So my BC is greater than AC, which is not normal. I hope you are getting it. People say yes. Got it? Yes or no? So this is the procedure. I hope you got the principle. I hope you got the procedure. Principle and procedure to theek hai. Okay. Nothing important. So what we are doing? First, we are activating here. Okay. We are activating here and looking for BC. Okay. We are activating and putting the fork here on the mastoid and measuring the BC. Okay. When it stopped, immediately we are putting the fork here and measuring the AC. Normally AC is longer than BC. So when it stop here and immediately we are shifting here, this should again start. This should continue. So it indicates AC greater than BC. Okay, got it? Yes or no? So what is the interpretation now? The most difficult portion is interpretation. I'm not sure whether you will get it or not, but I will try my best. Okay, listen. Okay, now, what is the interpretation? Normally AC greater than BC. We know that. No need to learn. AC greater than BC. Even a blind person can say, yes, the length of AC is greater than BC. Of course. So normally it happens. Okay. But in sensorineural deafness also, AC greater than BC. And this is known as Rinne positive. Rinne is positive seen in 2 conditions. Normally also Rinne is positive. In me, both the ears, Rinne is positive. Because I don't have any deafness. But if anyone is having sensorineural deafness, then also AC is greater than BC. He will say, ma'am, why? You do it, na? Here, you do it. I will mark the lesion with blue color. Okay. So in sensorineural deafness, you tell me where is the lesion. In sensorineural deafness, the lesion is not an external ear. It's not in middle ear. In conductive deafness, the lesion is an external or middle ear. In sensorineural deafness, it is an inner ear or the brain. Let's say here is the lesion. In the cochlea, sensorineural deafness, this is my lesion. So I'm talking about sensorineural deafness. And here is my lesion. Now do AC and BC. So AC, there is no problem till here. After that, there is problem. In BC, there is problem from the beginning. So you tell me what is the consequence? Of course, AC is greater than BC, like normal only. Because in sensory neural deafness, we have defect over here, not here. So in AC, from here till here, there is no problem. From here onwards, the wave will dampen if it is not 100% blockage. Maybe 50%, 40% deafness is there. So from here, the sound waves will dampen from here. But till here, it's normal. And after that, they will dampen after that. But in BC, they are dampened from the beginning itself. In BC, they are dampened from the beginning itself because BC directly activates the cochlea. So I hope here also AC is greater than BC. This funda holds good and you are getting it. This is my lesion. There is some problem in the cochlea. This is my patient. The patient is having some problem in the cochlea. You tell me, so what will happen? Problem in the cochlea. So AC may from here till here, no problem. But from here onwards, since problem in cochlea, so not 100% wave is transmitted. A portion of it will be transmitted depending on the intensity of the deafness. Got it? But from here, what you should ask him, ma'am, what if it is 100% deafness? That should be your question, but I will come on that point. Wait, I know your questions. Okay, but in BC, I mean, in sensory neural deafness, it's partial sensory neural deafness I'm talking. In BC, it is directly activating the cochlea, na? And from the beginning itself, the wave is dampened. So AC is greater than BC. Give me thumbs up, people, everyone. The only way you can communicate with me, keep on giving the thumbs up. That indicates that you are getting it. Okay. So normally and in sensory neural deafness, in both of them, AC greater than BC. So in Rinne's test, we can't differentiate normal from sensory neural deafness based on the results of Rinne. Okay, got it. Now, what about if reverse is happening? Now let me draw here. I can't erase. Let me try if I can erase the lesion. Where is my eraser? Oh, I'm having it. I got it. Now I will draw the lesion in conductive pathway. Let's try conductive deafness. Where is conductive deafness? Where should I draw the lesion? Either in external ear or middle ear. So let's say this is my lesion. Wax in the middle ear. Wax in the external ear, in the external auditory canal. So either the lesion in the external ear or middle ear. So you see what will happen. So AC will not transmit over here. AC will be obstructed over here only. AC is obstructed, but BC is 100%. In this case, there is no problem in BC. So here BC is 100%. You are getting it? AC got obstructed over here, but BC is 100%. So in that case, BC is greater than AC. I'm trying hard. So if reverse is happening, BC is greater than AC. It is known as Rinne's negative and it is seen in conductive hearing loss. But minimum deafness should be 15 to 20 decibel. 15 to 20 decibel, below which Rinne cannot detect. With Rinne's test, the minimum deafness we can detect is 15 to 20 decibel. If someone is having minor deafness below 15 to 20, that cannot be detected over here. People, everyone got it. Everyone. Anyone have any doubt? Do ask. So same thing is shown to you here. You can see the two arrows. This is AC, this is BC. Which one is darker? AC is darker than BC. It is Rinne positive. And here see the two arrows. Which one is darker? BC is darker than AC. So this is Rinne's negative. AC greater than BC, BC greater than AC. AC greater than BC seen normally and in sensory neural deafness. BC greater than AC seen in conductive deafness. You want to draw like this in your exam, you go ahead. One arrow dark, one arrow light. You want to draw like this, you can go ahead like this. Okay, you can see the two waves, AC, BC. Whatever is the way. You like my way, this is this diagram I have drawn. It is nowhere given in the book. You can go with this. Okay, now compare AC, BC and draw the lesion. If the lesion is here, what's going to happen? That is sensory neural deafness. And if the lesion is here, conductive deafness, what's going to happen? Use your common sense. If you have understood the principle, don't try to mug it up. So this is Rinne's positive, Rinne's negative. So there are three types of Rinne. One is positive Rinne, one is negative Rinne, and one is false negative Rinne. That is seen in 100% sensory neural deafness. Okay, I will tell you all three again. One by one we will see. What is positive Rinne? You already know, we will revise. What is negative Rinne? You already know, we will revise. But what is false negative Rinne? We will come on that. So what is positive Rinne? Say positive Rinne means AC greater than BC. Say it is AC greater than BC. So it happens in two conditions. In normally AC greater than BC, no need to explain. Obviously, even a blind person can see this line is longer than this line. So AC greater than BC, everyone knows. Normally, no explanation. But in sensory neural deafness, you have to write like this. Since there is a lesion either in cochlea or ahead of cochlea, either the lesion is here or ahead anywhere. Okay, anywhere. Cochlea, 8 nerve, brain, lesion in anywhere. That is sensory neural deafness, and lesion is anywhere over here from cochlea itself. Okay, so in that case, AC will come till here normally. After that, it will dampen. But BC is dampened from the beginning. Again, AC greater than BC. The same story is written. So some defect in the cochlea or in the brain. But there is no effect in the conductive pathway. You know, till here we have conductive pathway. This I call conductive pathway. This I talk cochlear pathway. So there is no defect in conductive pathway. There is defect in cochlear pathway. So again, that's why AC greater than BC. This is how you should explain in the exam. Okay, you understood, but this is how you have to write. In my class, everything is a flow chart. Everything is a diagram. Okay, no paragraph. Everything is a bullet. There is no diagram. There is no paragraph in my class. Okay, so this is positive Rinne test. Now coming on negative Rinne. Negative Rinne means kya? First you tell me the definition. What is the definition of positive Rinne? Say ma'am, AC greater than BC. And it is seen in two conditions. You should know the reason for both the condition. Now coming on negative Rinne. Negative Rinne is BC greater than AC. It's opposite. That's why we are saying negative. It's opposite. So this is the definition of negative Rinne. First write down the definition. Then tell me the condition. Only one condition in which BC greater than AC, and that is conductive hearing loss. In conductive deafness, there is some problem in the conductive apparatus. So conductive apparatus start from here till tympanic membrane. So defect is anywhere over here, either in external ear or middle ear. So suppose defect is here. Suppose defect is over here. So what will happen? AC will not transmit, no? AC will get obstructed over here. This line, the red line. It is obstructed over here only, but BC is going uninterrupted. BC is going uninterrupted. You can see the pathway. So that's why here BC is greater than AC. Bone conduction is normal, but conductive pathway is defective. And that's why BC is greater than AC. Okay, say yes. Okay, what is the doubt, Samanna? You can write it down. If you have doubt, please write it down. Okay, now coming on the third condition. I told you positive Rinne. What's the definition? AC greater than BC. See, positive Rinne. AC greater than BC. What is negative Rinne? BC greater than AC. That is negative Rinne. What is false negative Rinne? False negative. So it's negative felt by the patient, but actually not negative. What is negative Rinne? It's BC greater than AC. Patient feels so, but actually it's not that. So that is the definition of false negative. तभी तो false है, false negative. The patient feels negative, but actually it's not negative. That is false negative. You are getting my point. You are getting my point. That is false negative. Okay, so patient feels BC greater than AC, but actually it is not the case. Now what happens? This one happens in 100% sensorineural deafness. 100% severe sensorineural deafness. Do the sensorineural deafness here. Now with these tests, people try to learn. Whenever I say sensorineural deafness, you have to put a lesion over here. Whenever I say conductive deafness, you have to put a lesion over here, somewhere over here. You're getting it? So I'm talking about 100% severe sensorineural deafness. 100% deafness. Okay, 100% deafness. What will happen here? If it is 100% deafness, no BC. BC will not even enter. No BC, zero BC. Almost zero BC. BC will not, because it is 100%. It is 100%. Okay. And AC will come till here. And after that it is obstructed. So at least AC is coming till here, na? After that it is 100% obstructed. So again AC is greater than BC, no? You think, ma'am, common says this AC is greater than BC. In this case, if you are saying it is 100% obstructed, you are saying it is 100% obstructed. Severe sensorineural deafness. Not only here, it can be anywhere here, but it's 100%, almost 100%. Almost. Okay. So AC is coming till here. After that it is obstructed, but BC can't even enter. So AC is greater than BC. Now, ma'am, why? Why patient feel BC is greater than AC? Actually, it is AC is greater than, but patient don't feel so. If you perform the test in the patient, it's BC greater than AC. You must ask him, ma'am, why? That's why I'm saying, no, false negative. It's false negative. So you will say, ma'am, why it happens? Because whenever the tuning fork is capped at this mastoid, I will perform it. It's difficult. Suppose my right ear, can you see? Here, okay, I'm having 100% cochlear damage, 100% sensorineural deafness, severe unilateral sensorineural deafness. So what will happen? If I am activating it and I'm putting it here, zero sensation, zero. I should have zero because it is not even going to the cochlea. Cochlea is not even picking it because cochlea is 100% damaged. Okay, and in AC, it should go till cochlea and after that it is obstructed. So you say, ma'am, BC should not be felt and AC is subtle felt normally, but no, it don't happen. So whenever I keep it on the mastoid, the vibration, since they can't go here, so vibration, how should I show? I'm having a hairs. Vibration will cross and they will go activate the cochlea of this side. You got my point? Because none of the vibration is entering here. in BC, severe unilateral sensorineural deafness. None of the vibration is entering over here, no? So vibration will cross the cranial cavity and come here and activate this mastoid, although I am keeping the tuning fork this side only. But vibrations can cross the cranial cavity and they can enter this side. Okay, and activate this cochlea. So I can hear some BC, although this 100% cochlear damage is there. Okay, so here cochlea is not damaged, this side it's normal, so I can have still BC. So if suppose I don't have, but suppose I'm having 100% cochlear damage here, so what's happening? If I'm putting the tuning fork over my mastoid, I still can hear the vibration. It is not due to activation of cochlea of this side, it's damaged. How it can get activated? But vibrations are crossing transcranial and activating this mastoid, and I can hear the vibration because in the central connection it's the auditory cortex, one auditory cortex, it is reaching till there, I can hear. And if I'm doing the AC, it is faint. AC is not transmitting over here, so it is faint. So that's why patient feels that BC is greater than AC, but actually it's not, and that's why it is known as false negative. People, I tried very hard, no one will try so hard. Say yes if you got it. Everyone say yes if you got it. Okay, if you didn't got it, recap and watch this section, the last 3 minutes again. Okay, got it? Chalo. Let me change the scene. Yes. Got it, everyone? What you are asking, Sumanna? Let me read the comment. What you are asking? You can't find what is EC and BC, Sumanna. This is the pathway of the sound waves, na, Sumanna. The sound is traveling from here. It is starting from pinna. Via air it is going. Air conduction and reaching the auditory cortex. Okay, and BC mein sound is directly activating the cochlea. Okay, it is sound waves are directly activating the cochlea and reaching the auditory complex. Both of them are reaching the auditory complex in the brain area of 41, but the pathway is different. Okay, Sumanna, it was for you. You got it? So this is the tuning fork. I'm keeping it here. Suppose I'm keeping, so it is following this pathway. Via air it's going and reaching in my brain, I can interpret. And if I'm keeping it here, it is following this pathway. Okay, so because it is activating my cochlea directly and I can interpret. Interpretation is same in the auditory cortex. Okay, you got it, Sumanna? Thankfully you asked this question. If you have any doubt, please do ask, don't hesitate. Okay, G, give me a thumbs up, everyone. So you got what is false negative? False negative, I tried hard. In false negative, patient feels that BC is greater than AC. But actually it's not. This response is due to opposite ear because of transcranial transmission. So I'm activating this ear, but since here there is 100% cochlear damage, so that waves transmit from here to here via bone and activate this cochlea. So patient feels BC is greater than AC, but actually it's not. And that's why it is known as false negative. Okay, got it? False negative. Okay, Kanu, I will come on that, the bilateral hearing loss. Let me teach you Weber also. Then Kanu, only to you I will ask what will happen in bilateral. In bilateral, we will talk about 2 years. In bilateral, suppose I'm having bilateral hearing loss. Very good question. So if I'm having bilateral, now what is your question, Kanu? There are 3 options in the bilateral. I'm having conductive hearing loss in both. I'm having sensorineural hearing loss in both. Or I'm having conductive in one, sensorineural in another. Got it? Kanu, the answer of all 3 is different. The answer cannot be generalized. If anyone is having bilateral hearing loss, so we will talk about the 2 years in terms of better ear and worse ear. So the deafness is not equal in both ears. One of the ear will have less deafness, that is known as better ear, and one of the ear will have more deafness, that is known as worse ear. Then the results will be in terms of better ear or worse ear. Okay, better ear will be considered as normal and worse ear will be considered as the diseased ear. So in short, I have given you the answer, and better I will teach it after the Weber. Okay, so this is what we have completed till now. Okay, now you should ask me a question, ma'am. You told us the minimum deafness which is detected by the Rinne test is 15 to 20 decibel, below which we cannot detect with Rinne. But can we actually tell how much deafness the patient is having? Yes. You do the test. How much deafness is the patient is having? More than 20, but how much? How much the patient is having? You do this test with all these 3 tuning fork. I told you, not take all the frequency tuning fork. So all these 3 tuning fork should be available to you. 256 Hertz, 512 Hertz and 1024 Hertz. And you perform the same test. You perform. Suppose I am having not 3, but I am having 2 of them. Okay. So first I will perform the test BC followed by AC. Then I perform the test BC followed by AC. Rinne test. And the third one also I will perform. And I will see with which tuning fork I can detect the vibration. So if 256 is negative, but 512 and 1024 is positive, it is 20 to 30 decibel deafness. If 256 and 512 both are negative, only 1024 is positive, it's 30 to 45 decibel of deafness. If all three tuning fork is negative, Rinne negative in all three, so it's a deafness of more than 45 decibel. You are getting my point? So you get MCQs on that. You get MCQs on that. Only 256 negative, this much of deafness. Okay. 256 and 512 both are negative, this much of deafness. And all three are negative, this much of deafness. Below 20, we can't detect with Rinne. This is also an MCQ. I hope you all are getting it. Can we go ahead? Okay, got it. Okay, Ji. Okay, so this is what Rinne. So the summary of the Rinne. So what we are doing, we are taking a tuning fork. First we are putting it on the patient mastoid. Once it stops hearing, we are putting it in front of the ear, 2 centimeters away in front of the ear. Okay, now if the patient still continues hearing, it means AC greater than BC, it is Rinne positive. And if the patient is not hearing after shifting from here to there, so that is BC greater than AC and it is known as Rinne negative. Okay, got it? So we are done with the first test Rinne. Write down the summary of the Rinne. So what happens in Rinne? Normally AC greater than BC. In sensorineural deafness also AC greater than BC. But in conductive deafness, BC greater than AC. People. Before that, tell me the principle. What basically we are doing? Say ma'am, we are comparing AC and BC of the same ear with each other, and these are the results. Each and every one of you give me a thumbs up. Okay, got it? You can answer each other also. If you're getting each other doubt now, you should be interactive with each other, because I'm not getting sufficient time to read the comments and reply all of you. But definitely I will solve all your doubts at the end of the session. Don't worry. After ending these 6 tests, don't worry. I will solve all your doubts. But meanwhile, you can interact with each other, make a good community, and you can solve each other doubts if comfortable to all of you. Okay. Chalo. So we are done with Rinne's test. Say yes or no. Keep responding me, but. Chalo, can we start the next one? Before that, I'm having some questions for you. But I forgot to take my copy of the answers. I have to mark the polls now. So, shall I launch the poll? Or you will write the answer in the comment box itself? Write the answer in the comment box itself. Huh? Or you want me to launch the poll? For that, I need the copy. I have to go out and take it out. Anyways, you write the answer in the comment box. Read the question and tell me the answer. Rinne test is positive. When? Rinne positive. When? Normally, sensorineural deafness, conductive deafness, or A and C both. I'm sorry, A and B both. A and B both, not A and C. A and B both. Typing mistake. So what's the correct answer from ABCD? Please write down your correct answer in the comment box. What is the correct answer? Yes. So Rinne positive. I'm asking Rinne positive is when? So yes, most of you are right. The correct answer is not A. Bogala, the correct answer is D, na? The correct answer is D. So it is positive normally as well as sensorineural deafness, na? I have shown you here. So normally also and sensorineural deafness also. AC greater than BC, and it means Rinne is positive. So correct answer is D. I hope you got it. The next question is in front of you. What is the definition of positive Rinne? First you tell me the definition. What is the definition? What is the definition of positive Rinne? AC greater than BC? BC greater than AC? AC, BC both are same or none of the above? Very easy question. Very easy question. Say people say. What is the correct answer? Please write down fast. Positive Rinne means normal. What happens normally? Normally AC greater than BC. So correct answer is A. And most of you are correct. Very good. Very good. Most of you are correct. Very correct. Okay. Tell me the minimum deafness which is detected by Rinne. I mean, Rinne is negative below what? Whether deafness is present or absent, Rinne is negative below what? Tell me the minimum deafness, the cutoff deafness, which is detected by Rinne. Is it 15 to 20 decibel, 25 to 30, 35 to 40, or 15 to 50? What is the range? I told you. So the range is 20, 15 to 20. Deafness below 15 to 20 is not detected by Rinne. You should apply some other test, not Rinne. So deafness below that is not detected by Rinne. The cutoff of Rinne minimum should be 15 to 20. More than that, it is detected by Rinne, and we can tell how much deafness is there using different frequency tuning fork. I told you that criteria also. So correct answer is 15 to 20, and you all are done. Okay, chalo, let's start the Weber test. Can I start the Weber test? It's difficult, people. I mean, it's conceptual and tricky. So please focus. So let's start the next test, Weber test. Weber test. Let's start Weber test. In Weber test also, I will tell you the 4 things: principle, procedure, interpretation, and diagram. Let's start principle. My all test will be based on these headings only. You will find these headings on all my test first slide. So start with the principle. Let's start with principle. What is the principle of Weber? Here we take only BC, but of both here, not one here. We compare the BC of both here. Compare BC of right and left, both here. There what we were doing in Rinne, we were comparing AC and BC of the same year. This year, do BC, do AC and compare them. But in Weber, I'm comparing BC of my right and left ear. Both here, right here, we have only 2 years, I guess. Yes or no? So right ear, left ear, compare the BC of both of them, not AC. So learn the principle. Principle is the most important thing. If you understand the principle, the things are very easy. So see, this is my right ear. I guess you can see right, right, left, left. Right and left. Can you see my right and left ear? So this is my right ear. This is my left ear. So we are doing BC in my right ear. We are doing BC in my left ear and comparing it. So basically we are doing simultaneous BC in both the ears. Say ma'am, how to do simultaneous BC in both of the ear? For doing BC ear, you have to keep this mastoid. For doing BC ear, you have to do this mastoid. No. If I am activating the tuning fork and keeping it at the center of my head, vertex. This is known as vertex. The center of the forehead. Vertex. So both the mastoid will be activated simultaneously. Both the mastoid waves will go from here, 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 and both my mastoid bone activates simultaneously, and I can compare the BC. Yes or no? So vibrating tuning fork is placed at the vertex. I will do so. Okay. And patient is asked which ear hears louder. Okay. So normally which ear? This is also known as lateralization test. The other name of Weber. You learn the other name of Weber test. Weber test also known as lateralization test. Okay, because in case of deafness, it is lateralized to one of the ear. Okay, normally it is heard equally in both the ears. So interpretation, normally it is equal to both the ears. So let's perform it. People, this is my tuning fork. Okay, I'm activating it and keeping the foot plate at the center of my forehead. Closing my eyes so that I can focus. I can feel the vibrations both sides equal. More or less, I can try again. Yes, I can hear the vibrations both sides equal because I don't have any deafness, thankfully. Okay, got it. So normally, since I'm keeping the tuning fork, the vibrating tuning fork over here. Okay, here you can see the waves are generating. The waves will go here, 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 activating my mastoid. Okay, both the ears simultaneously. It is activating the mastoid of both ears simultaneously. You can see it here. So this is the mastoid of my right ear and this is the mastoid of my left ear. See the red lines. So my both mastoid, by doing so, you can see the waves are going and activating by this mastoid and this mastoid simultaneously. So from here also ecolema, from here also ecolema. So both the waves going to mastoid, from mastoid it's ecolema, reaching the brain simultaneously, and I can hear both the vibrations simultaneously. Normally there is no lateralization. Both sides the sound is same intensity, same duration. Say yes or no. So normally it is equal in both ears. Everyone can understand. No one will teach you these tests with such a clarity, people. I can challenge. Now this is normal. You tell me what happens in sensorineural deafness. You use your common sense. Now you draw here sensorineural deafness in one of the ear. Take my right ear as a testing ear. Draw sensorineural deafness in right ear. Where to draw? You know how to draw sensorineural deafness. You understand what is sensorineural deafness? The starting of my chapter. There should be a lesion in cochlea or head. That is sensorineural. So do a lesion over here. Do a lesion. Now you tell me. So this mastoid is activated? No, it is having lesion in the cochlea. It is not activated. But this will activate. Yes, this will activate. So I will not feel sound this side, but I will feel sound this side. So in case of sensorineural deafness, there is lateralization towards the better ear. So the same thing is written. It is lateralization towards the better ear. No need to learn. People, you can understand. I'm performing again. I'm performing again. So this is my right ear. You can see this is my right ear. Imagine this is my cochlea inside. I can't show you. It is my cochlea inside, which is defective. Okay. So what I'm doing, I'm activating the tuning fork. Do it again. Okay. Let's perform Weber test in sensorineural deafness. Okay, I am Dr. Priyanka. This is my right ear. In my right ear, I am having sensorineural deafness. Suppose, imagine, not actually. So what is sensorineural deafness? In which the cochlea or ahead there is lesion. So the lesion in the cochlea or head. Suppose there is lesion in my cochlea. Okay. Now what I am doing in my right ear, my cochlea is defective. That is, I am having sensorineural deafness. So I'm activating the tuning fork, keeping it my vertex. So sound waves are going and reaching here. Sound waves are going and reaching here. But this side mastoid activated, cochlea activated. But this side mastoid and cochlea are not activated or partially activated because it is defective. So sound waves are not reaching from this pathway, but sound waves are reaching from this pathway. So there is lateralization towards my better ear. Okay, so if I am having sensorineural deafness in my right ear, I can feel the vibration better in left as compared to right. But if I am normal, I can hear the vibration both sides equal. I guess I'm crystal clear. Yes, so this is Weber test. Say yes if you got it. This is Weber test. Okay. So this is what shown you here. But what happens in conductive deafness? In conductive deafness, we have to draw the lesion. Now you got it. Now again, right ear is the testing ear. We have to draw the lesion. Conductive deafness कहाँ बनाएंगे? Sensorineural deafness I always draw here. Conductive deafness we have to draw. I'm drawing conductive deafness here. Conductive deafness means there is a lesion in external or middle ear. Okay, that's why we have revised at the beginning. So there is a lesion over here. Say yes, there is a lesion over here. Now what will happen? If I'm activating the tuning fork and keeping it my vertex, so both side mastoid will be get activated. So now what is the problem? I mean, if there is a problem over here, no worries. Now waves are directly entering this here, bypassing the conductive pathway. Here also waves are directly entering from here, bypassing the conductive pathway. So ideally common sense says that it should be equal in both. In case of conductive deafness, the vibration should be equal because we are not testing conductive pathway. We are directly activating the bone conduction. Okay, we are testing the cochlear pathway in Weber. So in Weber, we are putting the tuning fork over here. We are putting the tuning fork. The waves, equal waves are going both the side. Since both the cochlea are healthy, they should be equal. But mind my words, it is better heard on the diseased ear. It is better heard on the worse ear. Say, ma'am, defective कान में ज़्यादा सुनाई दे रहा है? You mean that? Yes, I mean that. In the diseased ear, patient hear more vibration. In case of Weber, you tell me the reason. In case of conductive deafness, it is lateralized towards this ear only. Why? You tell me the reason. The diagrams are in front of you. You say, ma'am, it is activating directly this pathway. Here also it is activating directly this pathway. There is no defect in this pathway. There is no defect. It should be equal. Why you are saying it is more towards the diseased ear? Why? People, whenever we are performing any test, now there is 100% soundproofing is not possible. There is some background noise is also there. Currently, I'm having my AC background noise. I think you can't hear that, but I can hear a constant sound of my AC. A little bit background noise is always there whenever we are performing this test. That noise is known as ambient noise. Okay, ambient noise. So whenever the patient is having conductive deafness, that background noise is not coming. You are getting my point. So here background noise is not coming because background noise, conductive deafness is no. So background noise is not coming. But here there is no conductive deafness. So background noise is coming. Now you tell me, according to Weber, here the pathway is clear and here also the pathway is clear. So it should be equal. But here since there is no background noise, it is heard better in the worst ear. And since here there is a background noise, so it is heard little bit less. Okay, so again, I'm performing, people, the Weber in front of you. So, summary, everyone here, watch me, listen, Weber test. Okay, principle of the Weber test. What we do in Weber test? We compare BC of both the ears, bone conduction of both the ears. Okay, that is the principle. Procedure, take a tuning fork, 512 Hertz, activate it, keep it on the vertex, the center of the forehead, vertex. Vibrations are going here, activating my mastoid. Vibrations are going here, activating my mastoid. Both side vibrations are equal. I can draw the vibrations over here. I can draw the vibrations over here. Both the side they are equal. Now, three condition. What happens normally? What happens in sensorineural deafness? What happens in conductive deafness? Okay, normally, I don't have any lesion in none of my ear. My both ears are healthy. I don't have any deafness. So if I vibrate it, keep it at the center, equal waves go here, and I can feel the vibration both side equal. So there is no lateralization. Normally both side equal. no lateralization. But suppose my right ear is having sensory neural deafness. I'm having lesion in my cochlea, sensory neural deafness. So what will happen if I'm activating it and keeping it here? So waves are going here but not activating cochlea because it's defective. Waves are going here and activating the cochlea. So here I can feel the vibration, but here I can feel subtle vibration, not 100%. So I'm having lateralization towards the better ear. Okay, not the diseased ear in sensory neural deafness. Now come on the third situation, conductive deafness. Suppose here only I'm having conductive deafness. I'm having wax in my ear, wax in my external auditory canal. Okay, so what will happen? If I'm performing the test, I'm activating it and keeping in my vertex, you should say, ma'am, wax hai to kya hua? What happened if wax? Vibrations are going directly in the mastoid. Vibrations are going directly in the mastoid. Your both mastoids are healthy, ma'am. And it is going to the brain from the mastoid, from the cochlea. So they should be equal. I agree they should be equal in conductive. But since I have wax here, no, so background noise is not entering. Here I don't have wax. So here background noise is entering. So I agree the mastoids are both sides are equal. So waves are equal. But here in the diseased ear, I appreciate it better because wax is preventing the background noise. So the summary, in conductive hearing loss, it is lateralized towards the worse ear. So if I'm having sensory neural in this ear, sensory neural deafness in this ear, so it is lateralized towards the better ear. But if I'm having conductive deafness in this ear, so it is lateralized towards the worse ear. And if I'm normal, it is equal both. No lateralization. I tried harder. Very hard. Yes or no? People say. Huh? Okay. Got it? Everyone? Any relevant conceptual question you want to ask regarding Weber? Yes or no? I'm sorry. I'm going to change the scene. No. So that's not written in front of people. Now read the interpretation. You can interpret it better. If you everyone got it, why you are not giving the node that you got it? How I come to know that you got it? So this is the interpretation. Normally it is equal both the side. In sensory neural deafness, it is lateralized to the better ear. And in conductive deafness, it is lateralized to the worse ear. Okay, that's what we have done. Got it? Yes, so this is Weber. This is Weber. So the summary is in front of you. If it's normal, you can see. If it's normal, it's equal in both ears. You can see it's equal in both ears. When we are putting it on the vertex, same waves are going here, same waves. Okay. But in case of sensory neural deafness, this ear is having sensory neural. So this side mastoid is not activating. Only other side mastoid is activating. So it is lateralized to the better ear. But in case of conductive deafness, in case of conductive, both the mastoids are activated. But since here there is no background noise, it is appreciated better in the worse ear. Okay, lateralization towards the worse ear. Okay, everyone understood? I'm coming on the bilateral cases. Don't think about the bilateral. First you understand unilateral. I will come on the bilateral. Okay, unilateral there is no problem. So you can draw this diagram, you can draw my diagram, or you can draw this diagram. You can see here it's equal. The waves equal both the side. Okay, waves from here it is going, here it is going, activating both the cochlea, both the mastoid, equal, no lateralization. In sensory neural, it is towards the better ear. You can see a lesion in the cochlea, so it is towards the better ear. But in conductive, it is towards the worse ear. You can see wax in the EAC. So it is towards the worse ear. So this diagram is better to draw in your exam. Okay, G, can we move ahead? Huh? Got it? Okay. So here the minimum cutoff is 5 decibel. The minimum cutoff is 5 decibel. In Rinne, the minimum cutoff is 15 to 20 decibel. That can be detected in Rinne. But in Weber, minimum 5 decibel deafness, even a minimum 5 can be detected. But below 5, we cannot detect with Weber. If I'm having a deafness of 3 decibel or 2 decibel in one of the ear, so with Weber, it will be almost equal. I cannot differentiate it. Okay, so Weber ka minimum cutoff is 5 decibel in contrast to Rinne, which is 15 to 20 decibel. Everyone got it? So here I've explained why lateralization to the better ear in sensory neural deafness. This is what I have explained. Okay, because here one of the cochlea is not activated towards the worse ear, and in the better ear it is activated. And here I have explained why lateralization in the poorer or worse ear in conductive deafness, because there is no background noise. Okay, there is less disturbing or background noise because of the wax or the conductive deafness. So because the background noise is this, vibrations are better appreciated in the diseased ear, worse ear, poorer ear. Okay, so this is how you have to explain. Whatever I have explained, you have to write down in the form of the flow chart. I will share the notes, take the printout. So this is what we have learned. Now coming on bilateral, many students, whatever I am teaching, focus on that. Don't jump one step ahead. I will teach you everything, don't worry. But step by step I can go, no? Whatever I am teaching you from that, if you have any doubt, kindly do ask. If you have any doubt in the topics which I am going to teach you ahead, I will not solve that doubt. I will solve that doubt when I will teach that topic. Okay? Chalo, many were asking the doubt in bilateral now. Come on, everyone now. You answer. The one who were asking. Kaun tha? Huh? Come on, everyone. So bilateral. Now tell me 4 scenarios of the bilateral. If the person is having bilateral hearing loss, whether conductive or whether sensorineural, but it is less than 5 decibel. So what is the answer? You tell me the answer of the Weber in all 4. What will happen to Weber? If there is bilateral conductive deafness, what is the answer of the Weber? If there is bilateral sensorineural deafness, what is the answer of the Weber? And one side sensorineural and other side conductive. What is the answer? So there are 4 scenarios. Both the ears have conductive deafness. Both the ears have sensorineural deafness. One is having conductive, one is having sensorineural. Okay, and anyone which is less than 5. If it is less than 5, both the ears having deafness, but the difference between the deafness is less than 5. Weber is not lateralized. One by one, we will take the 4 conditions. Okay, the first condition, bilateral conductive, I'm having bilateral conductive deafness, or I'm having bilateral sensorineural deafness, but the difference between my deafness is less than 5. So it cannot be detected with Weber. Weber is not lateralized. Okay, I'm deaf, but Weber is not lateralized. Suppose I'm having 50 decibel deafness in this ear, and I'm having 52 in this ear. 52 decibel deafness in this ear. Deafness is measured in terms of intensity. Okay, 50 decibel, 50. So I'm having 50 decibel here, which is significant, and 52 over here. The difference is 2 decibel or 3 decibel. Okay, whether both have conductive, whether both have sensorineural, whether one is conductive, but difference is less than 5. So if I perform the Weber, here, okay, so I cannot differentiate it. Weber is not lateralized. Okay, so Weber is not helpful when the difference is less than 5. Take second scenario, bilateral conductive deafness. Bilateral conductive deafness. You use your common sense. What is happening in bilateral conductive deafness? Now see the 2 ears. Okay, here also wax. I'm drawing wax. Here also wax. Okay, I'm drawing wax. But the difference between the conductive is more than 5. Okay, what happens now? What happens? So one is better ear, one is poor ear. It is not both have just equal deafness. One is having 20 decibel, one is having 100 decibel. I mean, the difference is much high. Okay, so one is, I will call 20 decibel deafness is better ear, and 100 decibel deafness is poor ear. So I'm having 2 ear, both have conductive deafness, both have wax, or both have any conductive deafness, but one is better, one is poor. So what happens normally in conductive deafness to the Weber? Weber lateralized to the poorer ear because of the background ambience. So it is lateralized to the ear with more hearing loss. The same concept I'm applying. Okay, so suppose I'm having 20 decibel here, 100 here, and if I'm doing conductive hearing loss, if I'm doing the Weber, I will hear better where I'm having 100 decibel deafness, not in the 20, because of the background ambience, which is blocked more here as compared to here. So here background ambience is less blocked, here background ambience is more blocked. That's why I will hear the Weber better in my poorer ear as compared to my good ear. I hope I am able to explain you. The third, if I am having sensorineural in both, again 20 this side, 100 this side. So what will happen if I am using Weber? If I am using Weber, so waves are going here and waves are going here. I am here only 20 decibel deafness here, so it will activate my 80% mastoid. But here I am having 100%, so it is not activating my mastoid. So it is lateralized towards the good ear. So you know the answer. Concepts are same. In bilateral also, only thing you have to use your brain, use your concept. So Weber is lateralized to the ear with less hearing loss. Less hearing loss in case of bilateral sensorineural. Okay, and what happens now? The most trickiest question. I guess most easiest and trickiest. One ear with sensorineural and other ear with conductive. What happens? One ear with sensorineural, one ear with conductive. You understand here or you understand in me? Huh? Let's do here. Suppose this ear is having conductive, I'm drawing wax. And this ear is having sensorineural, I'm drawing cochlear lesion. So here conductive hearing loss and here sensorineural hearing loss. Okay, so in conductive, it is lateralized to the same ear, worse ear. And in sensorineural, it lateralized to the opposite ear, better ear. So in both the scenario, it is lateralized towards the ear which is having conductive hearing loss. So answer is it will be lateralized towards the conductive hearing loss. One ear with conductive, one with sensory neural, so it is lateralized to the conductive. You understood? Now everyone give me a thumbs up if you got the 4 scenarios. Yes, absolutely right. Shriyansh, absolutely right. Got it. These are the 4 scenarios of the bilateral. People were asking, no? So these are the 4 scenarios. Okay. So bilateral hearing loss, bilateral conductive, bilateral sensory neural, one with conductive and one with sensory neural. If it is bilateral conductive, it is lateralized to the poor ear. If it is bilateral sensory neural, it is lateralized to the good ear. And here it is lateralized towards the conductive hearing loss. And I have given concept for all of them. I know the topic is difficult. Okay. But we tried. And if it is less than 5, Weber is not lateralized, whatever is the difference. If it is less than 5 decibel, it is not detected with Weber. In all of these scenarios, it is more than 5. It is more than 5. Okay, I guess everyone got it, but only few are responding. Why? Huh? Why? So what we have done, chalo, we have done till now, we have understood what is Rinne's test and what is Weber test. So in Rinne test, we compare AC and BC of the same ear. In Weber test, we compare BC of both ear. See the principle. Here we are comparing AC and BC of same ear, one of the ear. That is Rinne's test. But in Weber, we compare BC of both ear. BC of this ear with BC of this ear. Got it? Everyone got it? Huh? So this is a summary of the Weber. Okay, compare it with the Rinne. Okay, here in Weber, normally it is not lateralized. In case of sensory neural, it is lateralized to the better ear, good ear, better ear. Okay, the ear with less deafness. And in conductive, it is lateralized to the worse ear. The diseased ear hears better. On the contrary, paradoxically, the diseased ear hears better because of blockage of the background noise. Okay, got it, everyone? You want to see it in a patient model? We'll try these 2 tests, Rinne's test and Weber test. We'll try. I guess everyone got it. If anyone having doubt, please do ask. So let me introduce my patient. I guess you can see my patient. There is much light over the mannequin. Yes. This is my patient. You can see the ear, no? Yes or no? It's white. This is the ear of my patient. I don't know whether you can see or not. So this is my patient. Let's perform. I'm the examiner, I'm the doctor, and this is my patient. I'm performing Rinne's test in my patient. My patient is having trouble in the right ear. This is the right ear of my patient. I'm the doctor, I'm the examiner, I'm ENT specialist, suppose. And this is my patient. Okay. So what I will do Rinne's test first. In the Rinne's test, this is my patient's disease ear. I will do AC and BC in the same ear and compare AC with BC in Rinne's test. So this is my tuning fork. I'm activating it. First, keeping it on the mastoid, asking the patient to feel the vibration. As soon as the patient say ki vibration stop, immediately I will convert here. I will shift the tuning fork over here. So normally AC is greater than, so patient should hear AC still after stoppage from here. Patient should still hear it. Yes or no? So normally AC is greater than BC. In sensory neural deafness also AC is greater than BC. But in conductive deafness, it is the BC which is greater than AC. You are getting it? It is the BC which is greater than AC. So that was Rinne's test and I have explained you the reason. Now we are performing Weber test in the same patient. Again, patient is having deafness in the right side only. We want to know whether it is conductive or whether it is sensory neural. With these tests, we are coming to know that because treatment of both of them is different. Okay. So what we will do here in Weber test, we compare BC. We compare BC of both the ears. BC. In Rinne's test, we compare AC and BC of one ear. In Weber test, we compare BC of both the ears. We compare BC of both the ears. You are getting it? So what I am doing here, I am activating my tuning fork and keeping it at the vertex. Keeping it at the vertex of the patient like this. Okay. So sound waves will go here, activate this mastoid. The same sound waves go from here, vibrations, and activate this mastoid. So both the mastoid is activated simultaneously with the same intensity if the patient is normal. If the patient don't have any deafness, sine waves goes here, and both side in the brain, it is interrupted same. So it is no lateralization. Patients say that I can hear sound both side equal. And there is no lateralization, it is normal. Okay, if the patient don't have any deafness, it's normal. You are getting my point. But suppose in this ear, patient is having sensory neural deafness. So again, perform Weber. So take the tuning fork, activate it and keep it on the vertex. So sound waves are coming here but not activating the cochlea completely because patient is having sensorineural deafness over here, defect in the cochlea. And this side it is going and 100% activating the cochlea. This side it is 100%. So this side patient will hear better. Okay, but from here, suppose 50% cochlea is damaged. So only 50% waves are going from here. But from here, 100% waves. From here to here, 100% are going. But after reaching to the mastoid, here 50% mastoid is activated. Okay, and here 100% because here 50% suppose it is damaged. So here 50% interpretation is going here and here 100%. So it is lateralized towards the better ear. So I will ask patient in which ear you are hearing better. So patient is saying I am hearing better in this ear. Not in this ear. This is my diseased ear, ma'am. I'm not hearing better in this. I'm hearing better in this. Okay, good. Sensible. So this is sensorineural hearing loss. But suppose my patient is having conductive hearing loss in this ear. Again, I'm performing Weber in front of you. Okay, so let's take the tuning fork, activate the tuning fork and keep it at the vertex. Okay, so you may think, ma'am, sound waves are going here, activating the mastoid, going ahead. Sound waves are going here, activating the mastoid, going ahead. There is no problem in the mastoid. Now there is wax over here. There is wax or there is conductive defect over here. They should be equal. Weber should be. But since here is conductive defect or there is wax, the background noise of the AC is not going. And here, since there is no conductive defect, so background sound is going. So ideally, the waves are equal. Activating the mastoid, both sides are equal. But since here no background or ambient noise is going because of conductive defect, for example, wax. And here background noise is going. So it is better heard on the diseased ear. Patient will be in shock. Ma'am, I'm hearing better in my defective ear. I don't know why, but I'm feeling vibrations good in my defective ear. So it is lateralized towards the defective ear. So that is a summary of the Weber. I tried really hard, people. Okay, so that was the summary. Every way I tried with the help of the models, with the help of the 3D animations and myself itself, I have done the experiments. I guess you must have got it. Okay, can we proceed now on the third test if you allow me? So let's move on the third test. Okay, sure. We will move on the third test. What is the third test? Before that, we have some questions. Okay, the first question is in front of you. Read the question, tell me the answer. Can you read the question and tell me the answer? Please, everyone, read the question and tell me the answer. Weber test lateralization to the affected ear means what? In the deaf ear, patient is hearing more. Suppose I am having deafness in this ear. Okay, and you are the examiner. You are performing Weber in me and asking, ma'am, which ear is better? My deaf ear is feeling better. Vibrations more better. So it happens in which deafness? What is the correct answer? Yes, you all are right. And Google has first to answer. Absolutely right. No, not the B. Narayana. Not the B. A is the correct answer. No, in conductive deafness, there is no background noise. That's why it is lateralized towards the worse ear. I told you, no? So correct answer is conductive deafness. Okay, the next question is in front of you. Everyone, please reply. If in sensorineural loss, in sensorineural deafness, Weber is lateralized towards which ear? In sensorineural. Suppose I am having sensorineural deafness in this ear. My cochlea is 50% damaged. Okay, and I am performing Weber. Okay, I'm performing Weber. This side I'm having sensorineural. So in which side it will be lateralized? Here only 50% waves will be transmitted, but here 100% will be transmitted. So it is lateralized towards the better ear. So the correct answer over here, you all are right. The correct answer here is normal ear. Better ear or normal ear. Okay, not the defective ear. Okay, so correct answer is normal. The next question in front of you, in right middle ear pathology. What do you mean by right middle? Where is my right ear? This is my right ear. I'm having a middle ear pathology. Middle ear pathology matlab kya? Conductive or sensorineural? Common sense. Start my session from the beginning. So right middle ear pathology means right conductive deafness. In other words, middle ear pathology. Instead of middle ear pathology, you read it conductive deafness. So right conductive deafness. Right conductive deafness. Which side it will be lateralized? In conductive deafness, it is lateralized to opposite side. I'm sorry. In conductive deafness, it is lateralized to the disease side only. So right conductive deafness, it is lateralized to right side only. So correct answer is C. You got the concept? Anyone who got the concept? So the main catch in this question to make it out that middle ear pathology matlab conductive deafness. If you know it is conductive deafness, in conductive deafness, Weber is lateralized towards the poorer ear. So answer is right only. Answer is, if I change the word from middle to inner, what is your answer? I'm changing one word in the question. Instead of middle, I'm using the word inner. Question में right is same. Right inner ear pathology. Right inner. Then what is your answer? Would you like to change your answer? You should change your answer. Inner ear pathology माने cochlear defect. Cochlear defect. It is sensory neural deafness. In sensory neural deafness, it is lateralized towards the other. I mean better ear. In that case, answer will be towards the left side. Yes, absolutely right. So these tricky questions come in your exam. People, tell me the minimum hearing loss which is detected by Weber. Weber test minimum cutoff which is detected by Weber. So of course, I'm not waiting for the answer. The correct answer is 5 decibel. Okay, in Rinne, it's 15 to 20. In Weber, it's 5 decibel. So let's start the next test, ABC, the third test. Can I start the third test? Let's start it quickly, people. Now. So we are done with Rinne's test. We are done with Weber test. And now I'm starting with ABC. Air absolute bone conduction. ABC. Absolute bone conduction test. What we are going to do here, the same headings. What is the principle? Here we compare BC. BC of the patient with BC of the examiner. BC of the patient with BC of the examiner. Okay, again both BC. In Weber also we were comparing both BC, but BC of right ear with the left ear of the patient. But here BC of the patient with BC of the examiner. Okay, so that's the principle. Principle is the most important thing in the entire session. Learn the principle. Method is very easy. So this is patient ear. This is examiner ear. Okay, opposite side it's happening. Chalo, theek hai. Okay, this is my patient and I am the examiner. Okay, although here examiner is written and here patient, we are opposite. Okay, chalo, I am the examiner and this is my patient. So what I will do, I will take the tuning fork, I will activate it. I will take the tuning fork. You can see it better now. I will take the tuning fork. Okay, I will activate it. I will keep on the mastoid of my patient and ask the patient, as soon as it is stopped, you tell me. Patient is saying stop, it stopped vibrating. As soon as the patient is saying it stopped vibrating, I'm keeping it on my own, checking whether it's actually stopped or not. So if I also feel stop, okay, so patient is normal. Considering I am not deaf, suppose just test kar raha hai, wohi beh raha hai, so okay. So the person who is the examiner, the person is not deaf, person is normal. We are considering that person is normal. So we are comparing the BC of the patient with BC of the examiner. This is patient. This is examiner. I will compare BC of our both. Okay, so I will take a tuning fork. I will activate the tuning fork. I will keep it on the mastoid of my patient. I will ask the patient, as soon as it stopped vibrating, you tell me the moment it stopped. Okay, you indicate by raising your index finger. So as soon as it is stopping, patient is raising the index finger that it is stopped, and the same moment I'm shifting it here and checking whether it's actually stopped or not. Yes or no? If it stopped, so the patient is normal, patient is not having any deafness. Okay, but if I still feel the vibration, patient is not feeling, patient said stop, but if I shift it and I feel the vibration, so my BC is greater than patient BC. So patient is having some sensory neural deafness. Patient is having some sensory neural deafness. Yes or no? So that's why patient feel that it stopped, but it's still vibrating. I can feel. So here it is activating the mastoid of my patient, and here it is activating my mastoid, examiner's mastoid. I hope you are getting it. People, what I'm doing, I have done this experiment in front of you. What else I can do? This is the best possible way I can teach you. Okay. So you can see here what we are doing here. So this is patient here, this is examiner here. So first we are putting the tuning fork here on the patient mastoid. Okay, as soon as patient say ki it stop vibrating, I'm shifting it on the examiner ear and keeping it on the examiner mastoid and seeing whether examiner is feeling it or not. So this is the method. You read it. So base of the vibrating tuning fork kept on the patient mastoid. Once the patient give the signal that it is stopped. Okay, it is no longer vibrating. It is stopped. It is shifted to the examiner's mastoid. Okay, patient ki mastoid se examiner ki mastoid pe. Okay, yes. Okay, yeah, the most important thing I forgot to tell you here. I'm sorry. Here with meatus occluded, here also meatus occluded. Okay, let me take this mannequin again and let me show you. It's easy because this is the only difference between this test and the next test. Okay, that's why it's important. I forgot to tell you. Listen, this is my patient and I am the examiner. Okay, this is the test ear, right ear. I always take right ear as the test ear. Okay, this is a tuning fork. I'm performing ABC, absolute bone conduction. Yes or no? So here I am activating the tuning fork. I am activating the tuning fork sorry, and keeping it on the mastoid, that's same, but closing the tragus. Closing the tragus. You know, in my ear, you can see this small portion here is tragus on the pinna. This is my complete pinna. This side, this small thing with which we close our ear. How you close your ear? With the fingers. Close it down. Don't put the fingers inside. Okay, just close your tragus against the external auditory canal. This portion is known as tragus. I hope you are getting it. What is tragus? This is tragus. Okay, so first I will close the tragus. Okay, I'm closing the tragus. This is the tragus of my patient over here. I'm closing it. I'm closing it and activating and keeping it on the mastoid. Okay, tragus, external meatus is occluded with the tragus. As soon as the patient say, yes, it's stopped. So I'm closing my own tragus and keeping it here. So both of us have tragus closed. So the tragus closed, meatus closed. That is the most important thing, and that will differentiate this test from the next test. So I hope you all got it. Okay, so let's come back. So the same thing is written. So first keep the fork on the mastoid of the patient with meatus closed, and then keep it on the examiner. When the patient says it's no longer heard, keep it on the examiner mastoid with the meatus closed. You can see this is my patient. Okay, I'm keeping on the mastoid with tragus closed. Tragus closed. Appreciate. And as soon as the patient says it's stop, giving a signal by raising the index. Okay, it stopped. I'm putting it on myself. This is examiner. Suppose it is me. Okay, I'm putting, but again my tragus is closed. Okay, so mind the word tragus closed and highlight it both the side. Meatus closed. Okay. So, you know, here conductive, the background noise we are not disturbing. In both the scenarios, we are closing the background noise. Closing the background noise. By closing the tragus, the background noise is blocked. Okay, meatus of both the examiner and patient is closed with the tragus to prevent the background noise. Please mind it. Now you tell me the interpretation. What is happening? What is happening? Here also this is tragus closed. Okay, here also it is tragus closed. Number one, we are closing the tragus of both of them. Okay, if BC of the patient is equal to BC of the examiner, it's normal. Okay, patient say I can't hear, I also can't hear. So it's normal. So in normal, both of them have same BC. Both of them. Patient here, same duration as that of examiner. Okay, got it or not? What happens in conductive hearing loss? My patient is having conductive hearing loss. Where is my patient? This is my patient. I will do conductive hearing loss. This is wax. I have occluded the ear, but this is wax. In conductive hearing loss also, we are activating directly the mastoid. Here also we are activating directly the mastoid. So it's same. Okay, because this pathway is anyhow bypassed in bone conduction. So in normal as well as conductive hearing loss, it is same duration. But what about if my patient is having sensorineural hearing loss? Suppose my patient is having defect in the cochlea. My patient is having defect in the cochlea. So my patient's cochlea is not activated or only 50% activated. Okay, but my cochlea is not defective. It is 100% activated. Okay, so I'm performing the test on my patient. My patient is having sensorineural deafness. Okay, so here I'm putting it. Patient's cochlea is not much activated. Patient says stop, but here I can still hear it. Okay, I can still hear it. So it is sensorineural deafness. But if the patient is having conductive deafness, the patient will hear the same duration because mastoid directly activated bypassing the conductive pathway, and I will hear the same duration. I hope you got it, people. I hope you got it. So this is the interpretation. This is the interpretation of this test, and this is how we perform it. So this is the interpretation. Normally, it is same as that of examiner. In sensorineural, in conductive deafness also it's same as that of examiner. But in sensorineural deafness, the duration is reduced in patient as compared to examiner. So we are comparing the BC of the patient with BC of the examiner with meatus occluded. Now coming on the next test. The next test is Schwabach test. Schwabach test, whatever you pronounce. Schwabach test. It's same as that of ABC. Only thing meatus is not occluded. You tell me what will be the consequence. Here in the next test, Schwabach test, it's same. It's same. The principle is same. Here also BC of the patient is compared with BC of examiner. Only thing, here we will not close the tragus. Meatus is not occluded. So we are not occluding the background noise. So the result will be little bit changed. Okay, the result will be little bit changed. So you can see what we are doing. Procedure is same. Procedure is same. You can see this is examiner, this is patient. First, it is kept on the mastoid of the patient with meatus not occluded. As soon as the patient says it stopped, now it is kept on own mastoid. Okay, with meatus not occluded. In contrast to ABC, where meatus of the patient as well as examiner is occluded. Here meatus of neither patient nor examiner is occluded. We are comparing BC of the patient with BC of the examiner. We are comparing BC of the patient with BC of examiner. If we are comparing BC of patient and examiner with meatus occluded, it's ABC. This test is known as ABC. You can see here meatus is occluded. Here also meatus is occluded. But if we are comparing BC of patient with BC of examiner with meatus not occluded, this test is known as Schwabach's test. Schwabach's test. I hope it's crystal clear till now. Yes or no? So same thing is there. The same procedure is there. Only thing meatus is not occluded. Okay. So what is the interpretation? Normally it's same. Normally it's same. Okay. Normally here and here it's same in patient and examiner. We are directly activating the BC. Okay. Here also and here also. But what happened in sensorineural deafness? You tell me what will happen. My patient is having defect in the cochlea. So my patient cochlea will not be 100% activated. Okay, but my cochlea is healthy. So my cochlea is 100% activated. Okay, so my BC will be longer than the patient BC. Yes. So if my BC is longer than the patient, if the patient BC is shorter than mine, it's sensorineural deafness. Okay, but what happened in conductive deafness? Suppose my patient is having wax over here. My patient is having wax over here. So ideally you should think, common sense say, ki ma'am, wax is not coming in this pathway. Here you are activating directly BC. Here also you are activating directly BC, ma'am. So it should be same. It should be same. In patient as well as examiner, it should be same because you are directly activating BC now. Wax is not coming in the pathway, but background noise, you forgot that. Here background noise will not come because there is wax, conductive defect. But here background noise will come. Here background noise will come. You are getting my point. So what I am saying, so patient here longer than the examiner. Patient here longer than the examiner. Okay. Achha, one more way of doing these two tests. I taught you two tests, ABC and Schwabach test. I will summarize these two tests in the mannequin again. Okay. Telling the main difference. Okay. The summary of these two tests. ABC and Schwabach test in our patient model. So this is our patient model. Everyone, please focus here. First two tests I have already explained very well. Rinne's test and Weber test. And now I am explaining you. The Weber and the Schwabach in this patient model. Okay. So there is another way also of doing this test. We should have a stopwatch. Suppose this is a simple watch, but suppose this is a stopwatch, for example. Okay. So what I am doing, let's start with ABC. I am teaching you absolute bone conduction, ABC test. So I will activate the tuning fork, keep it on the mastoid of the patient and look for how many seconds patient here. I will start the stopwatch. As soon as patient signal I stopped hearing, I will stop the stopwatch and see the second for 10 seconds, 15 seconds, 20 seconds for how many seconds patient was hearing. Then again I will activating the tuning fork and keeping it on my own mastoid. I am the examiner. Again I will start the stopwatch and see for how many seconds I am hearing the vibration, and I will compare the seconds in the stopwatch, the patient duration of BC and my duration of BC. So I will note the BC in my stopwatch. So first I will activate, keep on the patient mastoid and note it here, and then I will activate, keep it on my own mastoid and note the seconds here. You got my point? This is another way or better way. You can note down how many seconds. Okay, but if we are doing meatus occluded, so I'm activating, occluding the meatus and keeping it here and noting the time. I'm activating, occluding my own meatus and keeping it here and noting the time. So this test is ABC. This test is ABC. Here I have blocked the background in the patient as well as me. I have blocked the background noise. Okay. So what is the interpretation? Normally, it is equal. So patient here for 10 seconds, I'm also hearing for 10 seconds. Patient don't have any deafness. If I'm normal, if I'm considering myself normal. Okay, so if both of them have equal. But in patient, it is 5 seconds. In me, it is 10 seconds. So why it is less than patient? It is for shorter duration. If I'm activating it, blocking the tragus and keeping it here, patient here for 5 seconds. If I'm activating it, blocking my own tragus, okay, and keeping it here, I can hear for 10 seconds. So patient here for shorter duration. I hear for longer duration. Examiner here for longer duration. So patient is some defect in the cochlea. So patient cochlea is only 50% or less activated. That's why hearing for shorter duration. So patient is having sensorineural deafness. Okay. But me and patient are hearing for normal, for same duration, 10 seconds, 10 seconds. So either the patient is normal or the patient is having conductive deafness. In conductive deafness also, the conductive pathway is bypassed. I'm directly activating the mastoid. So the summary of the ABC, normally and in conductive deafness, it's same. 10 second, 10 second. But in sensory neural deafness, patient hear for shorter duration and examiner here for longer duration, 5 second, 10 second. This is a summary of ABC. Now coming on Schwabach's test. Okay, only one difference. Here we will not occlude the meters, neither of the patient nor of the examiner. I will activate the tuning fork, keep it on the mastoid directly without blocking tragus. Here again I will activate the tuning fork, keep it on the mastoid without blocking the tragus. Without blocking the tragus. You're getting it? So here the background noise is not blocked. Okay, so one by one take the three condition. Normally patient here for 10 second, me hearing for 10 second. So patient and examiner duration is same, means it's normal. Patient don't have any deafness, subject don't have any deafness. Got it? The first criteria. The second criteria, patient is having sensory neural deafness. If my patient is having sensory neural deafness, I'm activating it, keeping it here, patient here only for 5 seconds. But if I'm activating it, keeping it here, I'm hearing for 10 seconds. Okay, so patient is having sensory neural deafness, same as that of ABC. But the result differ in conductive deafness. People, here is a catch. In conductive deafness, suppose my patient is having wax. I don't have wax. Patient is having wax. So if I'm doing it, patient is hearing for 20 seconds. But I hear for 10 seconds. Huh? Yes, patient hears for longer duration as compared to examiner. It doesn't mean I'm deaf. No, deaf is patient only. But patient is hearing for longer duration as compared to examiner. Why? Because I don't have wax, so I have background noise. So I can't interpret it better. I hear only for 10 seconds because of the background noise. But patient have wax. Patient can't hear background noise. And that's why patient is appreciating the same vibration for 20 seconds. So patient is appreciating the same vibration for 20 seconds because patient background noise is blocked by the wax. But I can hear only for 10 seconds because my background noise is not blocked by the wax. I don't have wax. So the summary of Schwabach's test. Okay, normally patient and examiner have same duration. Okay, 10 second, 10 second. In sensory neural, patient have less duration as compared to examiner. That is 5 second and 10 second. And in conductive hearing loss, patient have more duration than the examiner. That is 20 second and 10 second. People had tried hard. You got it? Good. You didn't got it? Recap it and see it again. Because I have covered all the things here. Okay. Chalo. So that was the summary. Tried harder. Yes or no? Ha. Let's move further. 3 of the tests are done. Okay. Yes, Anushka, I guess I have answered your question. So here the catch is the background noise. Background, you are right, it should be equal, but background noise is interference. You can take the example of the wax. Chalo, so we are done with the 4 tests. Rinne is done, Weber done, ABC done, Schwabach's done. Can I come on the 5th one? Anyone who is live, alive, understanding, give me a thumbs up, people. Chalo, come on. Can we go ahead? Yes, still people are there. Why people don't interact? Many people are there, you sit quietly. Chalo. The next test is Binge and Gellé. Again, these both are same. Like ABC and Schwartz are same, na? Now Binge and Gellé, one by one we will take. So let's start with Binge test, the 5th one. Can I start with the 5th one? So let's start the 5th one. The 5th one is the Binge test. Let's start with the Binge test. So coming on the principle, Binge test. Here we are taking only BC of the patient, not BC of the examiner. BC of the patient, and we are looking changes in the BC of the patient by occlusion of the ear canal. By occlusion of the ear canal. Okay, got it? So we are testing BC of the patient. This is only patient, not examiner, only patient. And we will occlude the ear canal and we will open it and ask the patient when you hear better. On occlusion of the ear canal, you hear better, or on opening of the ear canal, you hear better. So we are occluding, opening, occluding, opening. Okay, and asking when you hear better. I hope everyone got it. I hope, let me tell you the interpretation, then I will do on the model. So there are 2 interpretation, Binge positive, Binge negative. You will say, ma'am, what happens on occlusion? What happens actually on occlusion? Let me tell you what actually happens on occlusion. Binge positive, whenever we are occluding the ear canal. Okay, suppose I'm occluding the ear canal. So here pressure will increase. Okay, on occluding the ear canal, I'm sorry, pressure, no change on pressure, I'm sorry. On occluding, the background ambient noise is reduced. So I'm occluding it, there is no background noise. There is no background noise. Since there is no background noise, so patient hear louder when the canal is closed and patient hears softer when the canal is open. Common sense, you do in yourself also. Okay, when you hear better when it's open, when you hear less softer when it is closed. Okay, like that. So this is known as binge positive. It happens normally as well as in sensory neural deafness. As well as sensory neural deafness. Can you do sensory neural deafness here? How to do sensory neural deafness? Sensory neural deafness is the deafness in the cochlea. In the cochlea. So the defect is in the cochlea. So here also, I mean 50% of the cochlea is damaged. 50% of the sound is going. We are not comparing it with anyone. Okay. Now the 50% which is going, that is heard better when the canal is open. And the 50% which is going, that is heard less better when the canal is closed. Obviously. So normally and in sensory neural, the result is same. It is known as binge positive. Binge positive means it is louder when the canal is open and softer when the canal is closed. This is known as binge positive. It is seen normally as well as sensory neural deafness. Now let's do conductive deafness. Let's do it. What is conductive deafness? Wax. Best example is wax. Do wax here. Now what will happen? Whether you occlude it or open, it's permanently occluded. So on occluding or opening, there is no effect. Patients say, I hear same. Patients say, I hear same. Whether you occlude or don't occlude, I hear same. So there is no change. No change. There is no change. Patient hears sound with the same loudness, whether on occluding the canal or opening the canal. It is binge negative. It is seen in conductive deafness. How many of you got it? How many of you got it? So this is binge test. This is binge test. How to perform it, people? Say it fast. How to perform it? My model. Again. Okay. Let's name this patient. What I'm doing? Binge test. In binge test, this is the test ear or defective ear of my patient. I am doing BC of the patient, not of the examiner, only of the patient. You say only of the patient. I am occluding the ear and doing the BC and opening the canal and doing the BC. So let's activate the tuning fork. Keep it on the mastoid. Ask the patient, can you feel the vibration? Yes. Now open, close the canal and see, do you feel the vibration? Yes. You hear better here or better here? Better here or better here? In open canal you hear better or in closed canal you hear better? Okay, suppose I am the patient. I am the patient. This is my defective ear. So I'm activating the tuning fork, keeping it here. I'm closing the canal, I can feel. I'm opening the canal, I can feel. But I can feel better when it is open. I can feel less better when it is closed. This is binge positive. This is binge positive. Got it? Everyone got it? Huh? But in sensory neural deafness, in normal and in sensory neural deafness, it is better when the canal is closed and it is softer when the canal is open. Obviously, okay, common sense because of the background noise. But when there is conductive deafness, there is already wax in the ear. Opening and closing of the canal doesn't matter because it is already having the wax. So suppose I'm having wax in this ear and I'm performing this test. So whether I open, whether I close, whether I open, whether I close, it's same because there is wax. So in conductive hearing loss, there is no change on opening or closing the canal because the background noise is permanently blocked. So that is binge negative. That is seen in conductive hearing loss. I hope you got it. Now coming on the last test of the tuning fork test, Gelle test. So let's come on the last test quickly, people. So we are done with binge test. It is louder. Why louder when canal is occluded? Because the background noise is blocked. And why softer when the canal is open? Because there is background noise. So normally it's like this. In sensory neural also it's like normal. Okay, but in conductive, it is same whether the canal is open or whether the canal is closed. Okay, coming on the last test, Gelle's test. Let's come on the last test. Can I come on the last test, people? You with me? Chalo. Gelle's test. What is Gelle's test? Same as that of binge. Here also we compare the BC of the same patient ear, not with the examiner, but we see the effect of pressure in the canal, not opening and closing the canal. We are looking at effect of pressure in the canal. So we will increase the pressure in the canal with the help of an instrument. The name of the instrument is Schiegel's speculum. Can you see this is Schiegel's speculum? I will put this instrument in the ear and increase the pressure and see whether the patient is hearing better, same or worse on increasing the pressure. So basically we are testing BC of the patient ear and we are looking for the effect of pressure, increasing pressure in external auditory canal. In binge test, we were looking for the effect of opening and closing the canal on the BC. Here again, we will see BC, but not effect of opening and closing the canal, the effect of pressure. If the pressure in the canal is increased with the help of Schiegel's speculum, what is the effect on the BC? You got my point? What is the effect on BC? So suppose I am the patient. And I am the patient. I'm not taking the model. I'm only the patient. So I'm performing Gelle's test in me. So what I'm doing, this is the tuning fork. Okay, I'm activating it and keeping it in my mastoid. Okay, I'm activating, and this is Schiegel's speculum. I'm going on increasing the pressure simultaneously and asking, I'm realizing on increasing the pressure whether the vibrations are feel better or same or worse. I can feel the vibrations. Just suppose this is the test here. Okay, I'm activating it and keeping it here. Okay, simultaneously I'm putting the Schiegel's speculum and increasing the pressure. On increasing the pressure continuously, vibrations are same or better or worse. That's what we have to see. I hope you got it. Now come on the interpretation. Come on the interpretation portion. What is the interpretation of this? Huh? What is the interpretation of this? Ask the patient the effect of hearing on increasing pressure. Whether it is BC is increased, decreased, or so again we have positive Gelle and negative Gelle. Positive Gelle and negative Gelle. In normal and in sensorineural deafness, what happens on increasing pressure? Here I am increasing the pressure with Schiegel's speculum. So on increasing the pressure, the tympanic membrane becomes tight. Yes or no? Increasing pressure go in EAC. First increasing pressure go in EAC. After EAC, it will go to the tympanic membrane and it pushes the tympanic membrane. This is tympanic membrane. It is pushing. The increasing pressure is pushing, and the tympanic membrane, it will raise the intralabyrinthic pressure. Okay, it will push the ossicle, and the ossicle will push the stapes, M-I-S, M push to I push to S push to cochlea. Okay, it will increase the intralabyrinthine pressure in the cochlea, which will cause immobility. You know, in the cochlea of the basilar membrane. Yesterday I taught you in the cochlea we have basilar membrane on which there is organ of Corti. So here there is immobility of basilar membrane and there is decreased hearing. So on increasing pressure, there is decreased hearing. You got the mechanism? Whenever the pressure is increased over here because of Schiegel's speculum, the increased pressure go to EAC. When it goes to EAC, it pushes the tympanic membrane. Tympanic membrane pushes the ossicle. First M push to I push to S push to cochlea. In the cochlea, the basal membrane becomes fixed and organ of Corti do not sense the hearing and hearing decreases. So here sound is not transmitted ahead because organ of Corti is not working. Basilar membrane vibrations are stopped because of increased pressure. So hearing is less. Normally also, and in sensorineural deafness also, the same mechanism. In sensorineural deafness also in same mechanism. But in conductive hearing loss, we are not talking about conductive. All conductive hearing loss, suppose it is fixed ossicle or disconnected ossicle. For example, here the ossicles are disconnected. Ossicles are disconnected. Okay, so on increasing pressure will transmit to EAC. EAC is transmitting and pushing the tympanic membrane. But tympanic membrane cannot push it to the ossicles because ossicles are disconnected or they are fixed. And they are not transmitting the pressure to the cochlea. And cochlea is still sending the signals. And here, there is no effect on increasing the pressure. And it is Gelle's negative. I tried, people. At least I tried. No one will try so hard. So this is Gelle's negative. So this is what the summary of the 6 test in front of you. We are done with the 6 tuning fork test. People, you have to tell me the principle of all 6. This is the summary. This is the table you have to make. You have to tell me the principle of all these 6 tests. Can you see the screen? What we are doing? In Rinne's test, say the principle. Just a second. In Rinne's test, we compare AC and BC of the same ear. This is the principle. Okay. In Weber test, we compare BC of both ear, right and left. This is Weber. Okay. Rinne done, Weber done. Now ABC and Schwabach test, they are same. In ABC and Schwabach, we compare BC of the patient with BC of the examiner. In Schwabach also, we compare BC of the patient with BC of the examiner. But here, meatus occluded, you can see tragus. Meatus occluded, meatus occluded. Okay, here meatus open, meatus not occluded. Okay, so that is the principle. Okay, now the next 2 tests, Binge test and Gelle test. Here we see the BC of the patient only, not of the examiner. Here also we see BC of the patient only, not of examiner. Here we see the effect of canal occlusion, EAC occlusion, EAC open and EAC occluded. The effect of these things on the BC, open, close, when the patient is hearing better, the BC. Okay, and here also we see the BC, but we see the effect of increasing pressure on BC. We put the pressure with the Schlegel spatula and we see what is the effect of increasing pressure on BC. So that is the principle, people. I tried my best. The 6 tests, the principles are in front of you. Can we revise that? Everyone with me. Rinne test, Weber test. Okay, ABC, Schwabach's test. Binge test, Gelle test. The 6 tests in front of you. Rinne, we compare AC and BC of the same year. See, same year. In Weber, we compare BC of the right ear and the left ear, the 2 ear. Only BC, not AC. Okay, in ABC and Schwabach's, we compare BC of the patient with BC of the examiner, BC of the patient with BC of the examiner. But here, meatus closed, here meatus open. Okay, and in Binge and Gellé, we see BC of patient only. There is no examiner. Here patient and examiner both, here patient, examiner both. Here only patient, no examiner. Here also BC of patient only, no examiner. We see the effect of EAC open and close on BC. We see here effect of increasing the pressure on BC. I tried really hard. So this is the principle and this is the interpretation. Interpretation you have to write down in 3 portions. What happens normally, what happens in sensorineural deafness, what happens in conductive deafness. I have explained you with the help of flowchart each and every thing of this table. And I guess we are done with these tests. Now there are some overall questions based on the 6th test. We will move that and we will move to the next test. Okay, chalo. Read the first question and tell me the answer. Are you people happy? You got all these 6 tests? They were hard, I tried. You got the concept? Write down at least in the comment box. Huh? Chalo. So, the first question in front of you. All are tuning fork test except. Which of the following is not a tuning fork test? There are 6 tuning fork tests, na? Schwartz test is the tuning fork. Schwabach's test is the tuning fork test. Rinne's test is a test. Weber test is a test. But Grant test is not a tuning fork test. I guess the correct answer is B. Okay? Yes, you are right. The correct answer is B. Okay, the next question is in front of you. Binge test is what? In binge test, we test what? In binge test, it's an audiometric test. We test AC, we test BC, or it's a special test. What is binge test? I told you, no? This one is binge test. This one. This is binge. So what we are doing? We are testing BC. The effect of occluding and opening EAC on BC. Yes. So correct answer is C and you all are right. The one who are answering, you are right. Correct. Okay. So we are done with the clinical test. Let's start the audiometric test. Can I start the audiometric test? Yes. Let's start it quickly. They are small. They are not very big. So let's start the audiometric test. In the audiometric test, I would like to start the first one. Audiometric tests are again 4 in number. You can see pure tone audiometry, speech audiometry, Békésy audiometry. Békésy is not used nowadays. Only 2-3 lines on that. And the 4th one is impedance audiometry, which is of 2 types and very important. Okay. So there are 4 types of audiometric tests in front of you. Out of the 4, these 3 are subjective and this one is objective. What do you mean by subjective and objective? So audiometric tests are of 2 types. What are the 2 types of audiometric test? Subjective audiometric test and objective audiometric test. What do you mean by subjective and objective? Subjective means here the response based on the patient consciousness. Patient will tell us whether I can hear the sound or not by giving some signal, by raising the index finger. Patient is telling. We are putting the headphones in the ears of the patient, giving sound of different frequencies of different intensity, and we are asking the frequency and the intensity at which patient can hear the sound, the minimum intensity. Okay, so we are based on patient response. Patient is telling us whether I can hear or not. So that is subjective. It is based on the subject. Subject is my patient. Okay, patient will tell me whether I can hear or not by doing some signage, sign coding. I will ask the patient, whenever you hear, you raise your index finger. We will keep the patient in an isolated room where it is soundproofing and patient can hear only this sound or no other sound. Sound with the headphone I will give. I will tell you the method. And there's a glass partition. On the other side, the examiner is sitting. Okay, so examiner asks the patient, whenever you hear the sound, I keep on increasing the intensity by 5 decibel. You tell me first time when you hear the sound, you raise your index finger. So the response is based on the subject. It is on a subjective test. So these 3 tests are subjective tests. Pure tone audiometry, speech audiometry, and Békésy audiometry. These 3 tests are subjective tests. I hope you are getting it. These 3 tests are subjective tests. Now this is objective test. Objective test is not based on patient. Even in unconscious patient, comatose patient, we can perform. So here again, we will put the earphone, we will put the sound in the ears of the patient, but here we will detect some physiological data rather than asking the patient, and that is be plotted in the form of the graph. We will not ask the patient whether you are hearing it or not. We will take some physiological data that will be plotted on the computer, some graphs or something. So it is not based on patient consciousness. Even an unconscious patient, we can perform that. So that is objective test. In the objective test, this is objective test. That is impedance audiometry. You get an MCQ on that. Impedance audiometry is objective test, which is of two types: tympanometry and acoustic reflex. Okay, these two. So total 5 tests I want to teach you. So there are 2 type of audiometric test. Subjective test, in which the response is based on the response of the patient. Patient is indicating whether I can hear or not. And the objective test, in which we don't ask the patient whether you are hearing or not. We are just plotting it, capturing whatever the patient is feeling on a computer in the form of graphs. Okay, so this is subjective test, which are of 3 type, and this is objective test, which are of 2 type. So total, I want to teach you 5 audiometric tests. How many of you are ready with this introduction? People, show some energy. Come on, please. Chalo. So I want to teach you these 5 tests. I want to teach you pure tone audiometry, speech audiometry, Békésy audiometry. These 3 are subjective test, tympanometry, and acoustic reflex. These 2 are impedance audiometry, which are objective test. Okay, total 5. Can I start with the first one? Let's start with the first one. The first one is pure tone audiometry, subjective test. I'm starting with the subjective test, and I'm starting with pure tone audiometry. Okay, pure tone audiometry is a long question in your exam, and you get many MCQs on that. I will show you the MCQs. So you have to describe your answer under these headings. First of all, introduction. What is pure tone audiometry? Which frequencies are tested? Which intensity is tested? How calibration is done? Then principle, method, and interpretation. Principle, method, and interpretation is like all other tests, diagram, all other tests. But these things you have to learn extra. Okay, let's start pure tone audiometry. So what basically we are doing here, it is the most common method of audiometry among all. The most common method is this one. Most common. So most common method of hearing assessment is pure tone audiometry. So here we are putting 2 things in the ears of the patient. We are putting the earphone and the bone vibrator. So we are putting earphones are there, and the bone vibrator is also there. Both of them are there. You know, earphones. So this is my earphone I'm having with me. Okay, so earphones are put, okay, in the ears, and bone vibrators are also put. Suppose I am the patient, so earphones and bone vibrators, and now in the earphone what will be played? Different frequency and different intensity sounds will be played. So the minimum intensity at which I can hear 50% of the speech, that will be taken as my threshold if I am deaf. Okay, so this is how we perform. We perform in both the ears one by one with the help of headphone. In the headphone, we play sound of different frequency and different intensity. You are getting it? So this is how it is performed. Okay, pure tone audiometry. So it is an instrument. You can see it's an instrument in which we deliver various frequency and various intensity. I will tell you which frequency and which intensity sounds via earphones and bone vibrators. So here earphones are there, behind their bone vibrators are also there, which are put on the mastoid and which are vibrating like the tuning fork. Okay, so bone vibrators and earphone are both. Earphone is for AC. Okay, and bone vibrators are for BC. So we will test AC and BC both. Okay, via earphones, we will give various sounds of different intensity, different frequency that will go via AC. And via bone vibrators, we will directly activate the mastoid. Okay, it's not visible here, but here bone vibrators are also there on the mastoid. They are attached. Okay, and when we will vibrate them with different frequency, with different intensity, directly BC will be activated. So this is the instrument. I hope you are getting it. Actually, it is performed like this. So this is the examiner, this is the patient. You can see the headphone, and behind the headphone there are 4 bone vibrators. So we test AC and BC with different frequency and different intensity. You are getting it? So which frequency we take and which intensity we take. People keep interacting. Okay. If it is only unilateral lecture, why don't you watch the recording later on? If you're watching it live, kindly keep interactive. Sometimes I feel I am disconnected. I mean, I'm not live. I'm just recording it. Say people, you are getting it? Pure tone audiometry. So what we are doing in the pure tone audiometry? We are taking an instrument in which there is a headphone, there is a bone vibrator. We are putting on the ears headphone, we are putting on the mastoid bone vibrator, and we via wires, we are providing different intensity, different frequency sound in both the ears one by one, and we are recording it here when the patient will indicate that I can hear. So this is pure tone audiometry. So which frequencies we are using here? Which frequencies we are using here? When you test AC, you have to start with 125, minimum 125. 125, then 250, then 500, then 2000, 4000, 8000. If you are testing BC, don't start with 125, directly start with 250. So learn the starting point, okay? Learn that. And it at 4000, don't go. So first and last we eliminate. For BC, we test only for this, okay? So these are the frequency one by one we will play. Now for intensity, we decrease the intensity by 5 decibel. We give maximum loudness and then we keep on decreasing at a step of 5 decibel. Okay. For example, I am starting with 100 decibel. Patient say yes, I can hear. I will go to 95. Patient say yes, I can still hear. Then I will go to 90. Patient says still I can hear. I will go to 85. Patient says still I can hear. I will go to 80. I will keep on asking by decreasing 5, 5, 5, 5, 5. Suppose till 45 patients say I can hear. 80, 75, 70, 65, 60, like that. Okay, 55, 50, then 45. Then after 45, at 40 patients say I can't hear. So the threshold of the patient is 45. Threshold of the patient become 45, like that. The minimum intensity at which the patient can hear. We start with maximum and we decrease it at 5 decibel step. You know, frequency is measured in terms of hertz. The unit of frequency is hertz. And intensity is measured in terms of decibel. Okay, so here we are measuring the intensity. Got it? Now calibration. The calibration of this instrument, I have shown you the instrument. Now, this is the instrument. It is calibrated like that. At 0 decibel, person can hear normally. Okay, if you connect this to me, okay, at all these frequency, you play any sound. At 0 decibel, I will say I can hear. You start with 100. 100, you decrease. You come on 0. From 100 to 0. At 0 also, I will say I can hear. In this year also, This is the calibration. 0 decibel means normal. We start. It is calibrated at 0. You are getting my point? It is calibrated at 0 decibel. For both air conduction and bone conduction, and there is no airborne conduction gap. In contrast to tuning fork test, in tuning fork test, you know, AC was greater than BC. Here AC and BC is equal. Here AC and BC are equal. Here AC and BC, there is no gap. It is known as AB gap. AC and BC, there is no AC-BC gap. AC and BC are equal. In contrast to tuning fork test, where AC was greater than BC, and it is calibrated that at 0 decibel, person can hear normally. Okay, person can hear normally. If you do this test in me, if you connect this with me, suppose you are the examiner, I am the patient. Okay, I'm coming to you. Doctor, I want to do my pure tone audiometry demo, just for screening purpose. You say, okay, madam, why not? Kindly sit. We are connecting a headphone in your ears. So here I have connected the headphones and the bone vibrators also. Headphones are connected, bone vibrators are connected. Now all these frequencies will be tested one by one. You most commonly, if you want to test it, go with the 500, or a mixture of all these frequencies is tested. So you are playing a sound in my ears via wires. You are playing a sound which is of these frequency, and you are starting with 100 decibel. At 100 decibel, I am indicating I can hear. Okay, you are reducing 95, I can hear. You are reducing till 0, I will say I can hear. In this ear also, first you will test this ear, sound is coming only from this ear, not from this. And then you will test my this ear, sound is coming from this ear, not from this. In both ears, I can hear till 0. So I am normal, I am not deaf. But suppose you started with 100, I can hear till 45. And after 45, I can't hear. So my threshold is 45. Suppose in this ear, the minimum I can hear 45. In this ear, minimum I can hear 0. So this ear is normal, but this ear deafness is 45. Because 0 is normal. Okay. So above the 0, whatever is the minimum decibel at which person can hear is the degree of the deafness. Okay. I tried, people. With this, I can't literally hear anything. These are blockers actually. Okay. Got it? Can we proceed? So that is how we conduct this test. Okay, G. So this is the calibration. So principle, what is the principle? What do we want to know? We want to know the lowest intensity at which the person can detect the tone of different frequencies. Person can detect the tones of the lowest intensity. We start with 100 and we keep on decreasing at an interval of 5 till 0. So 100, 95, 90, 85, 80, 75 likewise. Hana, normal person hears at 0. It is calibrated like that. Okay, so what are the steps? What are the steps? First, tell the patient that I'm connecting a headphone. Okay, now after connecting headphone, you will hear beeps of different loudness. You will hear beeps, first very loud, then less loud, then less loud, then less loud. You have to raise your hand or press the button when the sound is heard. Either raise your hand or we will give a button. If patient do not want to raise hand again and again and again, we will give a button. So if you are hearing the sound, you have to press that button. When you don't hear, don't raise your hand and don't press the button like that. Okay. So what are the steps? One by one, we will see the steps over here. See the steps over here. First, explain the procedure to the patient. Don't ask the patient to sit, go, and I'm starting the procedure. Explain the patient what we are doing. We are putting a headphone. Okay, it is connected via wires. The control is in my hand. I am the doctor sitting over here who is performing this test. And I will give you beeps of different sound. First, very loud, then less loud, then less loud. You have to raise your finger every time, whenever you hear. So whenever you hear, you raise your finger, I will reduce the loudness. Then again you hear, you raise the finger, I will reduce the loudness by 5 decibel. I will start with 100, you hear, you raise your hand. Then I will give you 95, again you hear, you raise your hand, like that. Okay. So I'll explain the procedure and obtain the consent. You have to take the consent. Okay. Seat the patient comfortably in a soundproof room. You can see the patient is in a soundproof room and there is a glass partition between the patient and the examiner. Okay. Place headphones. Okay. And bone vibrator, both. So headphones and bone vibrator, I don't have it, bone vibrator both. Headphones for AC, bone vibrator for BC. Okay. Select the test ear. You want to perform on the left ear or right ear, which ear? And you will give sound and vibration from that ear only. One by one we will test both the ear. Okay. Now pure tones of known frequency, one by one we start playing. Okay. We start with the loud sound, that is 100 decibels. And then we reduce it by 5 decibels intensity, and we notice the lowest intensity at which patient can just hear 50% of the sound, and that is taken as threshold. That is, we repeat the test with all frequency. First we conduct this at 125 hertz, then we conduct it at 250 hertz. Like at all frequency we are repeating it. Okay, and we are doing it in the opposite ear also, and we are making a audiogram, a graph. A graph is automatically, a software is there in the computer. Whenever patient is pressing the button or raising the finger, we are pressing the button. On the computer screen here, automatic a graph is generated, and that graph I will show you, that is known as audiogram. And we have to interpret, being a doctor, we have to interpret that graph to know the type of hearing loss, whether it is conductive or sensorineural or mixed, and to know the degree, whether it is mild or moderate or severe. Both the things can be known. So what is an audiogram? Audiogram is a graph. It is a graph. It is a graph that we are charting. That we are charting on the x and the y axis. Okay, you got the procedure, what we are doing? We are explaining the procedure to the patient, taking the consent, make him or her comfortably sit. We are putting the headphone for AC. We are putting the bone vibrators for BC. And we start playing the sound via wires in one of the ear, not both together. So either sound will come from this side, this headphone or this vibrator, or from this headphone, from this vibrator. So at all the frequencies, we will test it one by one. Suppose we are testing at 500 hertz. Okay, so I will start with at 500 hertz I am testing. Suppose I'm testing at 500 hertz. This is my frequency. I started with 100 decibel and I keep on reducing by 5 interval till 0 decibel. If the patient have no hearing loss, patient can still hear at 0. Okay, then I will repeat the same test with 1000 hertz. I will repeat the same test with 2000 hertz. Okay, or mixture of frequency, we will repeat the test. The same we will do in the opposite ear. We will test AC, we will test BC, and we will make a graph. These are the graphs. These are known as audiogram. These are known as audiogram. Now, how to interpret it? How to interpret it? We take the threshold for BC, and that is the cochlear deafness. BC is the cochlear deafness. Okay, and we take the threshold of we take the difference between AC and BC. The difference between AC and BC is the measure of conductive. I forgot to put that diagram. The 2-line wala diagram, basic diagram. I cannot go on that slide again. So this is the pinna. This is EAC. This is middle ear having MIS. Okay, and this is inner ear. In the inner ear, we are having the cochlea. And the cochlea, we are having the 8th nerve. This is 8th nerve. And it is going to E. colima. You remember that diagram? I have drawn 2 red lines over here. So from here till here, it's AC. And from here till here, from cochlea till here, this is BC. I call this BC. People, you remember that diagram? Huh? So what we are doing here, so the threshold of BC is cochlear deafness. We take the threshold for BC, the bone vibrators, 5 decibel intensity reduced. The minimum intensity at which the patient can feel the bone vibrator, that is taken as cochlear deafness. Okay, suppose I start with 100 decibel, patient can't hear it. 95, patient can't hear it. Okay, 90, patient can't. Patient here at 70. So the cochlear deafness is 70. Cochlear deafness is 70. You are getting my point. The minimum threshold at which the bone conduction test is done. That is there. Now we will test AC also. Suppose AC is at 100. Okay, so what is the conductive deafness? AC include conductive plus cochlear both. So 100 minus 70. 100 minus 70. ये total 100 है. उसमें से minus 70 is 30. That is conductive deafness. I tried at least. Nobody is going to ask you such a detailed concept because these you will learn when you will do MS in ENT. But as it is given in standard textbook, you never assume what you are going to get as MCQs in your competitive exams. You got my point? So whatever is the answer of BC, that is directly cochlear deafness. But whatever is the answer of AC, so AC minus BC is the conductive deafness. Okay. So with this diagram, we can understand this concept. So what we have learned? We have learned sensorineural deafness, conductive deafness. Sensorineural deafness is equal to the threshold of BC. And conductive deafness is the threshold of AC minus threshold of BC. These are the 2 formulas. If you understood, very good. If you didn't understand, learn it. Okay. So we have to calculate the threshold of BC. We have to calculate the threshold of AC. And this is how we can calculate how much deafness the person is having. Which type of deafness the person is having? Is it sensorineural or conductive? And how much intensity the person is having. People respond. You are getting it. So this is the interpretation. It was tough, but I tried. So this is how we are doing. Now in this audiogram, there are certain symbols. Okay. So we use blue line for the left and red for the right. You can learn R for R. Red for the right. Red line for the right. I will show you the graph. We use continuous line for AC and broken line for BC. You can learn B for B. Broken for BC and red for right. Okay. Red for right and blue for left. Okay. And broken for BC and continuous for AC. These are the codings we do. For right, everything is red. For left, everything is blue. You can see. Okay. So we are testing AC also. We are testing BC also. Okay. AC unmasked, masked. Unmasked means we are closing the meters, not closing the meters. BC also unmasked, masked. Closing the meters, not closing the meters. Closing the meters and not closing the meters means the background sound. When we are masking, there is no background sound. And if it is unmasked, there is background sound. I hope you are aware with these terminologies. So you have to just see the coding we use in the graph. So if any graph comes as an image-based question in your NEET PG or especially in INI-CT, you should be able to interpret it. You can see. So right graph is right here. Red graph is right here. R for R. And the blue graph is the left ear. You can see. So you see the right graph, you see the left graph. You are getting it. So at 250 hertz, what is the interpretation of this? Can you interpret it for me? You can see at 250 hertz, in both the ears, right and left, at 10 decibel, the sound is heard. At 500 hertz, again at 10 decibel. At 1000 hertz, again at 10 decibel. But at 2000 hertz, when I repeated the test, instead of 10, it's 15 hertz. You can see at 15, I'm sorry, not hertz, this is decibel. It is 15 decibel deafness. At 4000, the deafness is nearly 60 decibel. Okay. And at 8000, the deafness is nearly 80 decibel. Okay. So this is how we interpret this graph. The graph is corresponding for right and left. Sometimes it is different for right and left. Here the deafness and right and left is same, but sometimes it can differ. Got it? So I told you introduction, frequency tested, intensity. Which intensity? We reduce the intensity in terms of 5 decibel. Calibration is done at 0. 0 decibel is considered as normal. Okay, principle, what we are doing here, we've tried to find out the lowest intensity at which patient can hear 50% of the sound. So this is known as threshold intensity. Okay, steps I told you, interpretation I told you. Everyone give me a thumbs up if you got pure tone audiometry. We are done with this test. Okay, these tests are small, but they are complicated. But if you got the basics in the tuning fork, here you are getting it. Okay, so pure tone audiometry. How many of you got it, people? Everyone got it? Pure tone audiometry. Exactly what we are doing here. So I'm having some polls, some questions for you. The first question is in front of you. Red line in pure tone audiometer indicates what? Red line in pure tone audiometer indicates what? Bone conduction, air conduction, right ear, left ear. I told you a mnemonic also. People respond, come on, fast. I told you a mnemonic also. R for R. So red line is for right ear. Yes, yes, absolutely right. Red line is for right ear. Very correct. The next question, in pure tone audiogram, the symbol X represent. You have to learn these symbols, by the way. I didn't read you. So X indicate AC, unmasked. Okay, X indicate AC, unmasked in the left. So you have to learn these symbols. What does triangle indicate? What does square indicate? So AC in the left ear, unmasked AC in the left ear, like that. Okay, so you have to learn these symbols. So coming on the second one, speech audiometry. I'm teaching you objective test. I'm teaching you audiometric test. In the audiometric test, these three are objective and these two are subjective. So I'm teaching you objective test. Okay, objective mein pure tone audiometry is done. Now we are coming on speech audiometry. Let's come on speech audiometry. So in speech audiometry, there are two types of speech audiometry. I will teach you both. So what we are doing here in pure tone audiometry, we were giving beeps via headphone, different beeps at different frequency. Okay, frequencies are fixed, 125, 500, 1000, like that. And intensity, we start with the loudest and we reduce by 5 decibel. We are giving beep. Now again, I will put the headphone again, but instead of beep, there will be certain words which will be played in my ears. It will be not a beep. It is not like beep. There will be certain words that will be played and I have to understand and hear those words. Okay, that is speech audiometry. It is not about hearing. If someone can hear but can't understand the speech, we are getting my, so still the person is deaf. Okay, so it is not only about hearing. It is about hearing and understanding the speech. You are getting my point? Yes or no? So it's the speech audiometry. In speech audiometry, we judge the patient's ability to hear and understand the speech. Okay, so we put the headphones on the patient, and here in the headphones, certain words are there which are played one by one in the ear. Once in this ear, then in this ear, not simultaneously. Okay, so there are two types of speech test. As I told you, there are two types of speech test. What are the two types of speech test, people? What are the two types of speech test? Speech reception threshold, it is known as SRT, speech reception threshold, and speech discrimination score, SDS, speech discrimination score. I will explain the difference between the two. One by one we will start. They are very important. So let's start speech reception threshold, SRT, speech reception threshold. Let's start it. What is speech reception threshold? Here, the principle is that we want to find the minimum intensity at which the person can repeat 50% of the words correct. So suppose I am the patient, okay, and you are performing SRT in me. Suppose let's take the mannequin now. So let's take the mannequin over here. Okay, so this is my patient. Can you see my patient? This is my patient. Okay, now in this patient, I want to perform SRT. Okay, I will take a headphone. I will put the headphone in the ears of my patient. Okay, this is my patient. I'm putting the headphones in the ear of my patient and I will play spondy words. What are spondy words? Spondy words are verdict words like basketball, like daylight, butterfly. Such words are played. Okay, and I will ask the person to repeat what is played in the ear. And I'm having a list in my hand. I will check whether the person is saying right or not. I know what is playing here. Okay, I am having the list. The first word is sunflower. The second word is daylight. So when it is played, although I can't hear it, when it is played, I will ask the person to repeat whatever you are hearing from this ear. Okay, so the first word is sunlight and patient is repeating it's correct. So I will put a correct. The second word is butterfly, but patient cannot repeat it. Okay, so I will put a cross like that. Okay, so at least I want to know. So if the patient is not able to hear, I will increase the intensity, and I want to know the minimum intensity at which at least out of 100, 50% of the words are repeated correctly. And that is known as SRT, speech recognition threshold. Patient is able to recognize 50% of the words, whatever I am saying. At what intensity? Okay, so I will start with 0 decibel, then 5 decibel, then 10 decibel, then 15, 20, 30. I will see at minimum how many decibel patient is repeating 50% of the words which are played here. So I will play 100 words. Out of the 100 words, patient is repeating all of them. Maybe patient is normal and patient is repeating all 100 words correct. Maybe patient is repeating 70% words correct, 60%, 50, but 50 is the threshold. The intensity, the decibels at which patient is repeating from mouth. Patient is repeating at least 50% of the words which are played here. Out of the 100 words, 50% correct. That is known as SRT, speech recognition threshold. People, speech recognition threshold. Got it? So this is how we perform the SRT. Okay, so the same thing is written in front of you. Read it. Read it now. Okay. Let's keep this man here only. Chalo. So it is the minimum sound intensity. It is in decibel at which 50% of the words which are spoken here are said correctly by the patient. So this threshold, this intensity is known as SRT. So how to perform this test? I already told you on the patient. So a set of spondy words. What are spondy words? Two syllabus word. Two syllabus word like basketball, sunlight, daydream. Such 100 words are played in the ear. We ask the patient to repeat it. Okay, they are delivered to each ear one by one via headphone. So the minimum intensity at which 50% of the words are said correctly, repeated correctly, this is known as SRT. So we will recognize the SRT. And here SRT is within 10 decibel of pure tone threshold. In the pure tone audiometry also we have calculated the threshold. Now we start with 100 decibel, we reduce it, and we go till 0. For example, here patient is recognizing 50% of the sound at 45 decibel. So here also answer will be within 10 decibel of the 45. They coincide. Okay, so here it will be plus minus 10 decibel. Answer will be within 10 decibel of the pure tone audiometry threshold. The speech recognition threshold we have done. This is the first test. Now coming on the second test, it is speech discrimination score. People, hearing and repeating is not important. Understanding what the word is said, uska meaning kya hai, that is important. And that is known as speech discrimination score. Speech discrimination score. Here patient was receiving and repeating it. Here patient have to understand it. So here we want to know whether the patient is able to understand and repeat the words correctly. Patient is able to understand and then repeat it correctly. Okay, here just we want to know the intensity at which patient is repeating. Whether patient is understanding or not, it doesn't matter. But here we want to know whether patient is hearing as well as understanding it. That is known as speech discrimination score. So what we will do, again we will put a headphone like this only, and we will tell a list of phonetically balanced words. There we have taken spondy, two syllabus word. Okay, spondy words. Here we are taking phonetically balanced word. For example, pin, sin, day, bus. Okay, all these words. And we deliver to each ear separately at 30 to 40 decibel above the SRT. We already know the SRT. First we perform this. Okay, we already know what is the SRT of the patient. Okay, and 30 decibel above the SRT. Now we are sure. What is SRT? SRT is the intensity at which 50% of the words are correctly repeated. 50%, not 100%. It is a minimum intensity at which 50% are correctly repeated. Whatever is the minimum intensity of this patient, for example, it's 70 decibel. So 70 plus 30 at 100 decibel, I will deliver this. I already know the SRT of this patient. First, I perform the first test. So whatever is the SRT, I will add 30 to 40 decibel and then give a list of 100 these words and ask the patient to repeat them. Okay, so out of the 100, how many patient is repeating? That is said in terms of percentage, and this is known as PB score. Okay, phonetically balanced score. Phonetically balanced score. So this is in terms of percentage. Okay, in normal and in conductive hearing loss, it is 100%. 100% words are correctly repeated. Okay, but in cochlear deafness, the maximum 70% are correctly repeated. Okay, and in retrocochlear deafness, there is a phenomenon known as rollover phenomenon. It's difficult. I will try. You can see the graphs over here. Let me show you the graph. Can you see this graph? See this graph. So normally, person is repeating 100% of the words. 100% of the words at just 30 decibel. At just 30 decibel. 30 decibel is normal intensity. We talk with each other at 30 decibel. If you say 100 words, sin, pin, cat, bat, mat, at normal intensity, at 30 decibel, I will hear all of them and I will repeat 100% correct because I don't have any deafness. But if I have conductive deafness, I will repeat 100% of the words correct. But instead of 30, I will repeat it at 80 or 90. My intensity. So you have to shout, sin, pin, bat. So at higher intensity, I can repeat it correct. I can repeat it correct. But in cochlear deafness, in cochlear sensorineural deafness, maximum 70% of the words can be repeated at whatever intensity. Even on increasing the intensity, it will be 70%. Out of 100, only 70% words can be repeated correctly, not more than that. The highest is 70. The highest, on increasing the intensity, the highest is 70. This is cochlear deafness. In retrocochlear deafness, listen, at lower intensity, more words are correct. At higher intensity, less words are correct. I mean, if I'm saying at low intensity, like cat, bat, mat, patient will give more words correct. But if I'm shouting cat, bat, mat, less words are correct. You say, ma'am, how it is possible? This is known as rollover phenomenon. This is known as rollover phenomenon, which is seen in retrocochlear. I will explain why. I will explain. So first you understand what is rollover phenomenon. In speech discrimination test, normally, if you increase the loudness, the score will improve, no? If I say cat, bat, mat, there is a chance you hear out of the 100, you hear 80, 90. But if I shout cat, bat, mat, 100% will be right. So on increasing the loudness, score improves. Score improves. But in retrocochlear deafness, after a certain point, on increasing loudness, score reduce. On increasing loudness, score reduce. Okay, after a certain point. Okay, speech understanding actually worsens. Okay, on increasing loudness, score reduces. So if I'm saying it slowly, I mean on a less loud, cat, bat, mat, person is saying it correctly. But if I'm shouting cat, bat, mat, score is worsening. This is known as rollover phenomenon. First you understand what is there and you should be able to draw this graph. Okay, now you understood. Now I will tell you the reason for rollover phenomenon. In rollover phenomenon, just there, put that slide. In rollover phenomenon, there is cochlear nerve damage or brain damage. You understand? Rollover, I mean, what is retrocochlear deafness? Retrocochlear deafness means 8th nerve damage. I told you, na, cochlear, retrocochlear and central. So retrocochlear mein 8th nerve is damaged. So when you are increasing the loudness, the nerve fibers become overstimulated. They become overstimulated and they are unable to transmit the signal, and that's spawning the score. And this is known as rollover phenomenon, and you get question on that. You're getting my point? So normally at 30 decibel only, the score is 100%. 100% words are repeated correctly. Which words? Phonetically balanced words. It is known as PB score. Phonetically balanced score. PB words. 100% is repeated correctly. But in conductive hearing loss also, 100% words are repeated correctly. But not at 30 decibel. It is at 80 decibel. It is at 80 decibel. So normal is done, conductive is done. Sensorineural mein we have two types of sensorineural, cochlear, retrocochlear. Cochlear mein maximum correction is 70. 70 words out of 100, only 70 words are repeated correctly. Even on increasing the intensity after that, okay, the score don't improve. But in retrocochlear, there is rollover phenomenon. After a certain intensity, say 80 decibel, even on increasing the intensity, the score falls. On saying louder words, the score is falling actually, and I told you the reason for that. So this is the now why we are doing this speech discrimination test, because we want to put the hearing aid. When we want to put the hearing aid, we want to set its volume. In the hearing aid, there is an option of setting the volume. So we will set the volume at which based on the PB score, we will set the volume of this. Okay. And this can differentiate cochlear from retrocochlear deafness and sensorineural. So these are the two uses of speech discrimination test. So we are done with two tests over here. What are the two tests? Speech reception, speech discrimination. In speech audiometry, I taught you two tests. What are the two tests here in speech audiometry? Speech reception test, speech discrimination test. What is the basic difference? Here we found the minimum intensity at which person is repeating 50% of the bisyllabus words correctly, spondy words correctly, the minimum intensity. And here we want to test the person's ability to understand and repeat the phonetically balanced words. That is single word, pin, bat, cat, like that. Okay. So here answer is given in decibels. And here answer is given in percentage. Okay. And I told you the use of that. People say the third one is the Békésy. The last objective. There are three objective audiometry. Na? I told you pure tone audiometry, how to perform that. I told you speech audiometry, how to perform that. Now Békésy is same as that of pure tone. The only thing in pure tone, the control was in examiner's hand. Na? You remember pure tone? There is a patient, there is examiner, there is a glass slide in between, and patient raise the hand every time, and examiner is raising or falling by 5 decibel interval. Here we give the control to patient. It's self-operating machine. It's self-recorded audiogram. We give the control to the patient. Okay, the patient have the button. Patient can increase or decrease the intensity by 5 decibel, 10 decibel, and patient himself or herself said, this is the minimum intensity at which I can hear. Okay, but it is not used nowadays. This is known as Békésy. It is self-recording audiometry. Patient control the intensity through a button. I will ask the patient, I will give the button to the patient. Patient will increase, decrease, increase, decrease, and patient see at minimum what intensity I can hear in my right ear, in my left ear. This is known as Békésy, but not used nowadays. It looks like this. It is self-control audiometry. So we are done with these three. We are done with these three audiometry: pure tone audiometry, speech audiometry, and Békésy. Yes or no? People say na, speech audiometry is of two types: speech reception threshold and speech discrimination score. Yes or no? So you want me to revise the three? These are the three type of audiometries. You can say pure tone, speech audiometry, and Békésy. This is pure tone, in which we want to know the minimum intensity at which patient can hear 50% of the tone. Here beeps are played in the ears. Beeps or different intensity, different frequency. We want to know the minimum intensity, minimum decibel at which patient can hear the beep. Okay, 50% of the beep. Okay. And the control is in examiner's hand. The examiner is decreasing it by 5 decibel interval, and we want the patient to let us know the minimum intensity at which the patient can hear 50% of the beep. So that is known as a threshold for this. It's a beep. Okay, here also it's a beep. In Békésy, it's a beep, but it's self-control. Patient will increase or decrease. Here there is no examiner. Here there is a patient and an examiner. Here only patient, no examiner. Patient will set the intensity at which patient can hear that sound. And there is speech audiometry, in which we have two tests: speech discrimination test and speech reception threshold. In speech reception threshold, we give bisyllabus words. And we want to know the minimum intensity at which patient can repeat 50% of the words. Okay, this is the threshold. So whatever is the threshold, we add 30 decibel in that. And we give phonetically balanced word, a set of 100 phonetically balanced word in each ear, like bat, cat, pin, sin, like that. Okay, and we ask the patient to repeat it, to understand and repeat it. Okay, so that score is known as PB score. And I have shown you the graph of 4 PB score. How is the PB score normally? At 30 decibel, it's 100%. In conductive deafness, it's 70-80 decibel, it's 100%. In cochlear, maximum, it's 70%. Then even on increasing intensity, it's not increase. In retrocochlear, there is rollover phenomenon. That's what I have explained you over here. I hope you are getting it. People say. So we are done with the subjective test. Now the last test is the objective. I will finish this topic because in the next lecture, starting from the middle will be difficult. It will take 10 more minutes, but I will pack it. So coming on the objective test. Are you there? Keep responding, people. Say. So subjective tests are done. I taught you 3 subjective tests. Okay. So this is my patient. Okay. And I want to perform the 3 subjective tests. The 3 subjective type of audiometry in my patient. Okay. So this is my patient. First, I will perform pure tone audiometry. So I am taking a headphone I'm putting it on the ears of my patient, and I'm taking bone vibrators, putting on the mastoid of my patient. Okay, headphone is for AC, bone vibrators is for BC. Okay, and I'm having an instrument, I don't have it actually, and that is known as pure tone audiometer. And the headphones are connected via wire to pure tone audiometer. In pure tone audiometer, I deliver, suppose this ear I'm testing. So I will deliver in this ear beeps of different frequency, different intensity. You know the frequency, you know the intensity. Intensity wise, I start with the highest, 100 decibel, and I reduce it at an interval of 5, and I ask the patient to tell me the minimum intensity at which 50% of the beep is heard. That is taken as threshold. That is known as pure tone audiometry threshold. This is what we are doing here. I told you the principles, steps like that. Okay, so this is pure tone audiometry. Now coming on speech audiometry. There are two types of speech audiometry. First is speech reception threshold, SRT, speech reception. Here also I am putting just headphone, no vibrator, only headphone to the patient. Suppose I am testing this ear. So in this ear, 100 bisyllabus word, which are known as spondy words, will be delivered, like sunflower, basketball, daydream, like that. Okay, ask the patient to repeat it. Okay, so minimum intensity at which 50% of the words are correctly repeated. I have given a set of 100 and the patient is repeating it. Okay, so at the intensity, whatever is the decibel, the intensity at which 50% of the words are correctly repeated, that is taken as SRT threshold. Okay, speech reception threshold, SRT threshold. It will be in certain decibel. Okay, so that is the amount of deafness the person is having, because that is the minimum threshold at which the person can repeat 50% of the words. Now I will do the second test, that is speech discrimination test, in which I want to know the patient's ability to understand the speech. So again, I'm putting the headphones. You can see I'm putting the headphones. Okay, and no vibrators, and again I'm testing this ear. So I'm giving a set of phonetically balanced word. It is known as PB. Okay, so these words have a meaning, like these are closely same pronunciation word, cat, bat, mat, but they have different meaning. So they are known as phonetically balanced. So patient can repeat it if patient can hear and understand. So cat, bat, mat, like that. Okay, so patient is hearing it and repeating. So at what intensity we are delivering? We are delivering at the intensity which is 30 to 40 decibel above the SRT. We have already done SRT. We know the threshold at which patient can repeat the words 50% words correctly. So 30-40 decibel above that, we are expecting patient to say 100% words correctly. Okay, so we are delivering at that intensity, 100 phonetically balanced word. In SRT, we have given spondy words, set of 100 spondy words. But in SDS, I mean speech discrimination test, we give a set of 100 phonetically balanced words, and we ask the patient to understand and repeat it. Okay, so we have made the graph. A normal person can repeat 100% of the words correctly at 30 decibel. A person with conductive hearing loss can repeat 100% of the words correctly at 70 decibel. Okay, 70 to 80 decibel. But person with sensorineural deafness are of two types, cochlear, retrocochlear. The cochlear deafness can repeat maximum 70% of the words. Even on increasing the intensity, I keep on increasing from 30, 40, 50, 60, 70, 80, 90, 100 decibel. Patient score is not improving. The correct word said is maximum 70% in cochlear. In retrocochlear, paradoxically, there is a phenomenon known as rollover phenomenon. So at a frequency of 70, till 70, the score improves. After 70, the score falls. I mean, even on increasing the loudness of the sound, the score is falling. So whenever I am delivering the words at low intensity, the patient score is more. Patient is saying words correctly, more words correctly. But whenever I am giving the sound loud, we are expecting that at loud sound, the score should improve. But rather the score is depriving. Okay, it is falling. So that is known as rollover phenomenon. I have explained you the reason for the rollover phenomenon also. After that, there was the third audiometry, Békésy, which is self-control. Here also in Békésy, we put the earphone and we give a button in the hands, a remote, a button in the hands of the patient. Patient himself or herself will increase or decrease intensity and set intensity for himself or herself, at which the 50% of the sound is heard. So we are delivering the sound and patient is increasing or decreasing the intensity. So that is self-control audiometry. People, I tried, at least I tried. Okay, I am satisfied. I tried my 100%. So that is audiometry. We are done with the subjective test and now I'm starting with objective test. So let's start objective. These all tests were based on the patient response. Now let's start the objective tests, which are not based on the patient response. Okay, they do not rely on the patient corporation. We can do them in the comatose patient, in infants and children also. It is known as impedance audiometry. You can see impedance audiometry, which is of two types: tympanometry and stapedial reflex. Both we will take one by one. Tympanometry and stapedial reflex. So let's start with tympanometry. What is tympanometry? Very important. Here we will make the graph. What is tympanometry? In tympanometry, I will teach you two things: principle and method. So what is the principle of tympanometry and interpretation? So what is the principle? Here in the ear, there are three principles. You have to understand there are three principles in tympanometry. What are the three principles? You can see this is tympanic membrane. Can you see this is tympanic membrane? So when a tone, this is a tone which is played in the ear. So when the tone is going, it is falling on the tympanic membrane. 50% is absorbed and 50% is reflected back. You know that it's normal. So whenever the tone is falling, the sound energy is falling on the tympanic membrane, 50% is absorbed. Not 50% exactly. A portion of it is absorbed and a portion of it is reflected back. Not 50%. I take my words back. A portion of it is absorbed and a portion is reflected back. Please see. Whenever a tone is played on the tympanic membrane, a part of it is absorbed and a part of it is absorbed, part of it is reflected back. Now you will say, ma'am, how much portion is absorbed and how much portion is reflected back? Who will decide? It is based on the stiffness of the tympanic membrane. It depends on the stiffness of the tympanic membrane. If the tympanic membrane is very hard, it absorbs less and reflects more. But if the tympanic membrane is loose, okay, fluctuant, loose, it absorbs more and reflects less. So if the tympanic membrane is stiff, very hard, stiff, it reflects more. It reflects more. Don't absorb. Hard things don't absorb. Hard things just reflect. But if it is the compliant one, it absorbs more and reflects less. You are getting my point? So this is the principle. If you understood the principle, you give me a thumbs up. Shall I proceed? You understood the principle? So I am teaching you tympanometry. I told you the principle. So whenever the sound is falling on the tympanic membrane, this is tympanic membrane, a part of it is absorbed, a part is reflected. How much absorbed and how much reflected depend on the stiffness, whether it is hard or soft. If it is hard, it reflects more. But if it is soft, it absorbs more and reflect back less. Got it? This is the principle. Now, one more principle you have to learn. You have to learn two principles. This was the first principle I told you. How much is the absorption, how much is the reflection from the tympanic membrane depends on the compliance of the tympanic membrane, whether it is stiff or whether it is loose. Okay, this was the first principle. Now coming on the second principle. The second principle, absorption. How much is the absorbed? First thing, it depends on the stiffness. And second thing, it depends on the pressure in EAC. How much pressure? We are increasing the pressure or reducing the pressure in the EAC with the help of an instrument, with the help of a pressure pump over here. So the second thing, the absorption, but depends on the pressure. Maximum absorption occur when the pressure in EAC is same as that of environment. The outside pressure and EAC pressure both are same, maximum absorption occurs. If in the EAC pressure is more than outside or pressure is less than outside, in both this scenario absorption is less and reflection is more. You are getting my point? Maximum absorption occurs when the pressure in EAC is same as that of pressure, not environment, I'm sorry. Pressure in EAC is same as that of middle ear. Pressure of tympanic membrane, both sides of tympanic membrane pressure is same. Then maximum absorption. This is the second principle. So if you learn the both principle, now see the method. It's very easy. So what we are doing in the ear, we are putting a device. The name of this device is impedometer. It is having 3 channels. Impedometer. Like this we are connecting. This is the ear. This is impedometer. I have connected in the ear. It is having 3 channels. What are the 3 channels? One is oscillator. This is known as oscillator, with which pure tones are delivered. Pure tones are delivered at different decibels, different intensity to the ear. Number 1, it is the oscillator. This is known as oscillator. At a fixed frequency, it delivers the tones. Okay. The second instrument is known as pump. This is known as pump. Okay, which is connected with a manometer. So we can set the pressure. We can increase or decrease the pressure in the EAC. So this is the pump, pressure pump. Okay, which is connected with a manometer, and we can set the pressure in Pascal. in decapascal. We can set the pressure. Okay. And the third instrument here is known as microphone. This one is microphone. So this one is delivering the tone, and once the tone is going, it's reflecting back. A portion of it is reflecting back. So whatever is coming back, whatever tone is coming back, it is detected by that. It is detecting that. How many of you got it? You got it? Okay, so what we are doing, we are taking an instrument which is known as impedometer. It is having 3 channels. It is having oscillator, microphone, and a pump. Oscillator is delivering pure tone. Okay, pump is bringing the pressure changes in the EAC, increasing or reducing it to see the effect of pressure. And microphone is picking up the reflected sound. So here, from here, the sound is going, a portion is absorbed, the remaining one is picked by the microphone. You're getting it? So these are the 3 channels, impedometer, we are connecting. So what's the procedure? Again, this is my patient. I am putting impedometer in the ear of my patient. So from here, I am putting pure tones. Oscillator. Okay, from here, I will do pressure changes. I will increase as well as decrease. I will start with 0, then I will see the effect on increasing, then I will see the effect of decreasing. Okay, and here, whatever sound it is going, a portion of it is reflecting back. Whatever reflecting back is detected by microphone. So this is the complete method. So the instrument is like this. We are putting impedometer like this, and it is having the 3 channels. It is having these 3 channels. Okay, and the effect of pressure, and the changes in the pressure and the microphone which is detecting the reflected back, it is plotted on a graph. You can see this is on a tympanograph. It is automatically plotted. Okay, so we are doing pressure changes over here based on the pressure. This is fixed. It is not changed. We are giving a pure tone constantly. We are keep on changing the pressure based on the pressure. Absorption is different, reflection is different. We keep on increasing the pressure, decreasing the pressure, 0 pressure. So every time absorption proportion is different, reflection. Whatever reflection is collected by microphone, so the changes in this and according to this changes in this are plotted on a graph, and that is known as tympanograph. I'm trying hard, people. So what is tympanogram? What is we are charting the tympanic membrane compliance in proportion to the pressure changes, in response to the pressure changes. So this graph is known as tympanograph. Okay, the last thing, tympanograph. There are 5 type of patterns we observe here. Basically 3 patterns. Graph A, you can see graph A, graph B, and graph C. A is of 2 types, AD and AS. So total 5. If you consider the 2 variants of A, so total 5 are there. So graph A, graph B, graph C, and A is of 2 types, AS and AD. Okay, so you can see here, this is pressure. So we start with 0 pressure difference. 0 pressure difference, I mean same pressure. The pressure in EAC and middle ear is same. And we see the compliance, how much is reflected back. Then we reduce the pressure, we increase the pressure, and we see how much is reflected back. How much is reflected back, that is detected. How much is reflected back, that is detected by microphone, that is known as compliance of the tympanic membrane. I hope you are getting it. That is known as compliance of the tympanic membrane. So this is how we plot it. There are 5 type of graph. So first is graph A, B, C. And A is of 2 types, AS and AD. So total 5 types are there. Let's start with simple A. A is normal graph. Can you see where is A? Let me plot A. Can you see where is A? I told you the principle. Huh? What was the principle, people? Huh? So this is graph A. Let me highlight the graph A. This is graph A. This graph is known as graph A. It is normal. It is bell-shaped. Normal bell-shaped graph with peak at 0 pressure. You can see at 0. The peak is at 0. Now on increasing pressure from 0 or on reducing pressure on 0, the compliance fall. Compliance, maximum compliance at 0 pressure difference. You are getting it? So maximum compliance when the pressure difference is 0. You can see this is tympanic membrane. So pressure this side and pressure that side is same. That is 0 pressure difference, maximum compliance. Okay, now if you increase the pressure or reduce the pressure, compliance fall. Compliance, that is detected by the microphone over here. Microphone will detect the reflected back. That is the compliance. I hope you are getting it. So this is bell-shaped. This is bell-shaped. Maximum compliance at 0. And on increasing as well as reducing, the compliance fall. So if you do my tympanogram, it will be like this. Okay, so this is normal. What is AS and AD? The 2 variants of A. So let's start AS. It's a type of A. Where is AS? Where is AS? You can see this one. This one is AS. Now appreciate A and appreciate AS. This is A and this is AS. So it is having the bell shaped only. It is bell, but low compliance with low peak. Low compliance with low peak. Okay, low compliance with low peak. So low compliance at 0. So at 0 only it is having maximum activity, but low compliance as compared to normal. Low compliance. It is seen in fixation of ossicles like autosclerosis. Very important question. For example, these are fixed. These ossicles are fixed. There is a disease known as autosclerosis in which the stapes get fixed. The footstep of stapes. I will explain. So this is autosclerosis. Suppose they are fixed. So even on increasing or reducing pressure, okay, so the compliance will reduce, but you know, at 0 pressure also there is reduced compliance. So you have to learn AS type of graph is seen in fixation of ossicles, autosclerosis. AS. AD is also a type of AS. What is AD? Here is AD. Where is the graph of AD? This one. High compliance as compared to normal. Appreciate normal. So it is having high compliance with high peak. High compliance with high peak. AS was low compliance with low peak. AD is high compliance with high peak. Okay, so high compliance at 0. It is seen in ossicular dislocation. Just opposite. If ossicles get fixed, it's AS. If ossicles get dislocated, it's AD. Both are related to ossicles. If the ossicles get fixed, so compliance falls. If the ossicles get dislocated, compliance increases at 0. So this is what you have to learn. Okay, now coming on type B. So we have seen A, AS, AD. Okay, A, AS, AD. I will revise all 5. Now coming on type B. Type B, the flat dome shape. It is known as flat dome shaped tympanograph. No effect of pressure. Whatever is the pressure, is it 0, minus, plus, no effect of pressure. Compliance is almost same. No effect of pressure on the compliance. It is seen in fluid in middle ear. If there is fluid in the middle ear, even on increasing pressure, decreasing pressure, it is not passed ahead. So fluid in the middle ear, like serous otitis media, this type of pattern is seen. And the last one, last one, type C. What is type C? It is having a peak in the negative pressure. Can you see type C over here? It is also bell-shaped. But the peak is towards negative as compared to normal. The P's, it is seen in retracted tympanic membrane or Eustachian tube dysfunction. If the normally tympanic membrane is like this, but if the tympanic membrane is retracted, it's like this curvature. In Eustachian tube obstruction, this type of pattern is seen. You can understand if the tympanic membrane is retracted, so on negative pressure, it will equalize and maximum compliance will be there. If you are giving a negative pressure from here, so it will push and become equalized on negative pressure. You are getting my point? So this is known as type C. So what we have learned? We have learned 5 type of tympanogram. 5 type of tympanogram. Can we revise all 5? You can see this is normal A. A is normal. Okay, with maximum compliance at 0. On increasing and decreasing pressure, compliance reduces. It is bell-shaped. Now AS and AD are the types of A. AS seen in autosclerosis or ossicle fixation, and AD, D for dislocation. AD, D for ossicular dislocation. Okay, this one is AS, S for sclerosis. It is autosclerosis. So ossicle fixation, ossicle dislocation. Okay, this is low peak, low compliance, high peak, high compliance. Apart from that, we have B, which is flat or dome shape. No effect of pressure on the compliance of the tympanic membrane. Okay, no effect of pressure. So it is seen in fluid in the middle ear. And this one is C, that is peak towards the negative. It is seen in retracted tympanic membrane like Eustachian tube dysfunction. So I guess we are done. Polls I'm skipping. We are done with these tests, people. Okay, I hope you all got it. Say yes. Huh? So these tests I have completed. I tried harder to complete them. Only one of them, stapedial reflex, is the pending, that I will put as a video later on. It's not very important. So only the last one is pending. So we have completed these tests successfully. Okay, just give me a minute. Since the time, I'm also tired and time is also, we don't have much time now. So we will cover it in the next session. And most of the tests are done. Here you can see most of the tests we have completed all of them. We have completed this one, and from impedance audiometry, tympanometry. Only this reflex is pending. from the audiometric test. Special test, only one of them is important, Bera. Special tests are not important. You have to learn their name, only one. So only this one and special test mein Bera. These two are pending that I will cover in the next session, or I will put as a recording later on. So we are done with the test. So kindly revise them. If you have any doubt, kindly do ask. And I guess you have my number also. You can put the doubts on the support number. They will share the doubts with me and I can answer you later on. Okay. So today's demo is also done. The 2 ENT demos are done. Now for the next 5 days, we don't have a class. By the way, happy Diwali to all of you in advance. And we are having Diwali ahead. Maybe it is prosperous for you. After 5 days, we are having our ophthalmology demo. So we are having ophthalmology demo on the 23rd of October, in which I will teach you a very important topic, that is errors of refraction and accommodation, and that too on YouTube, not on the app. So see you after 5 days in ophthalmology demo, okay, on 23rd of October. Okay, so that's all about it. Thank you so much. If you have any other query, kindly text it on the support number. Thank you for being with me till end, the students who still survived after 3 hours also. Thank you so much. Bye-bye. Good night. I'm feeling very hungry now and I would like to end the session. Bye-bye. Good night. I hope you got it. Okay. Bye-bye. Bye-bye.